So we're discussing here the development of stomach. See, if anyone is not able to understand, no, please leave the class and go and sleep. Understand? Don't sit and break your heads on this. Clear? If you're not able to follow. And that is what I can say. If you're not able to follow, just go and have a sleep. You're not fit to join MBBS and you're not fit to give the PG exam. Okay, fine, I'll start. Just have a look. Now when the stomach develops from the foregut. Okay, the stomach is like this. It has got two surfaces. One is the right surface, one is the left surface. Two borders, anterior border and posterior border. Two ends it has got, a cardiac end and a pyloric end. Now the stomach undergoes a rotation here. The first rotation is along this axis, a vertical axis, and the stomach undergoes a rotation like this, like this, like this. So the left surface now becomes anterior and the right becomes posterior, like that. That's the first rotation. Okay, so the left surface becomes anterior and the right becomes posterior. Now, still the cardiac and the pyloric end, they are in the same line. Now the stomach undergoes a second rotation. The second rotation is along this axis. What is this axis? Anteroposterior axis. The stomach undergoes a rotation like this. The pylorus comes to lie at a higher level. The left border grows rapidly to form the greater curvature, and this becomes a lesser curvature. Okay, that's how the stomach is formed. And during development, this is the ventral mesogastrium and that's the dorsal mesogastrium. As the stomach turns like this, the dorsal mesogastrium also goes to the left side. It goes to the left side, and that's how a space is formed behind the stomach. What's that? Lesser sac. So lesser sac is formed behind the stomach. That's because of rotation of the stomach. Now, what I was telling you is this. Look at this slide. And the stomach, the anterior border of the stomach is attached to the anterior abdominal wall by what? Ventral mesogastrium. The anterior border of the stomach is attached to the anterior abdominal wall by ventral mesogastrium, and the posterior border is attached to the posterior abdominal wall by dorsal mesogastrium. Just have a look here now. So this is the stomach here. That's the stomach here. Now this is the ventral mesogastrium. That's the dorsal mesogastrium. So from the anterior border of the stomach to the anterior abdominal wall, this is the ventral mesogastrium and that's the dorsal mesogastrium. Okay. Now, someone is developing in the ventral mesogastrium. Who's forming in the ventral mesogastrium is the liver. The liver is derived from what? The GIT. The liver is derived from the GIT. You get a small diverticulum from the GIT. Just one moment, I'll put a slide for you. The liver develops from the GIT. A small diverticulum which is known as the hepatic diverticulum, and this hepatic diverticulum is growing towards the ventral mesogastrium, and the liver grows in the ventral mesogastrium. It forms in the ventral mesogastrium, because of which this ventral mesogastrium gets divided into one. What is this? Falciform ligament, and what's that? Lesser omentum. Okay, falciform ligament and the lesser omentum. So this falciform ligament, lesser omentum, these are all derived from ventral mesogastrium. Plus, just see this, what I was telling you in the morning. Look, just try to understand this. Just one moment. Look, this is the liver here. That's how the liver is. And what is this now? That's the diaphragm. See this slide which we had drawn. This is the liver and that's the diaphragm. We have taken a sagittal section. You remember? And what is this? What is this coming from the anterior abdominal wall? This is the this was the peritoneum coming from the anterior abdominal wall going to the diaphragm, and now it gets reflected on the liver like this. It gets reflected on the liver. You remember? The peritoneum coming from the anterior abdominal wall goes to the diaphragm and now gets reflected on the liver. So if you see the superior surface of liver, on this superior surface you find a line here, and this is the line of reflection of the peritoneum from the diaphragm to the liver, and this is what we call as the superior layer of coronary ligament. Okay, you understand? The liver is fixed to the diaphragm here, so the peritoneum will come from the anterior abdominal wall, will go to the diaphragm, and it can't cross the diaphragm. It gets reflected to the liver, and this is what we call as the superior layer of coronary ligament. Now the peritoneum from behind, from the posterior abdominal wall, comes up to the diaphragm, can't cross this and gets reflected to the liver. So what is this line behind known as the inferior layer of coronary ligament? So if you see the superior surface of liver, you find two lines here. One is the superior layer of coronary ligament, which is a reflection in front, and one is the inferior layer of coronary ligament, which is a reflection from behind. And if we join these two on the right side, this is what we call as the right triangular ligament. And if you join these two on the left side, this is what we call as the left triangular ligament. And with the help of this two triangular ligament, the liver is fixed to the diaphragm. Understanding? And this part of the liver, between the superior layer, between the inferior layer of the coronary ligaments, the right and the left triangular ligament, that big area is known as the bare area of liver. Bare area, okay? And the liver is fixed to the diaphragm here. So because the liver grows in the ventral mesogastrium, all the ligaments of the liver will be derived from ventral mesogastrium. Clear? Because the liver grows in the ventral mesogastrium, all the ligaments of liver will be derived from ventral mesogastrium. You're clear with this? What is that superior and inferior layer? Simple. From peritoneum, from the anterior abdominal wall, goes up to the diaphragm and gets reflected to the liver. Okay, what is this line of reflection known as superior layer of coronary ligament? The line from behind, the peritoneum from the posterior abdominal wall, goes to the diaphragm and gets reflected on the liver. What is that known as inferior layer? And you join both this on the sides. This is the right triangular and that's the left triangular ligament. So these are all the ligaments of liver, and all these ligaments of the liver would be derived from ventral mesogastrium. Okay, so this is what you have to know. Understand this. So now we are starting with derivatives of ventral mesogastrium. Derivatives of ventral mesogastrium. Derivatives of ventral mesogastrium. Okay, derivatives of ventral mesogastrium. 1. Lesser omentum. One is the falciform ligament. We'll start with falciform ligament. Falciform ligament. Falciform ligament. And what is this falciform ligament contains? This you have to know. Contains ligamentum teres. Contains ligamentum teres. And this falciform ligament contains the ligamentum teres, and this ligamentum teres is the obliterated left umbilical vein. Okay, they are superior and inferior because one is on the upper side and one is on the lower side, so we don't call them as anterior and posterior. One gets reflected from the upper level, it's at a higher level, so that is why it is known as superior, and one gets reflected at a lower level, that is why it is known as inferior. Okay, that was good. Why is it known as anterior and posterior? It is not known. It is known as superior and inferior layers of coronary ligament. Okay, so falciform ligament, what is this falciform ligament contains? Contains the ligamentum teres. And what is ligamentum teres? It is the obliterated left umbilical vein. Obliterated left umbilical vein, and there are small veins around the umbilicus, and this small vein around the umbilicus gets the small veins around the umbilicus, they anastomose with the veins of anterior abdominal wall. Normally this anastomosis is very small, but in case of portal hypertension, this opens up, and this is what forms the caput medusae. So what are these small veins around the umbilicus? The para-umbilical vein. Para-umbilical vein. Okay. So what are the contents of falciform ligament? Falciform ligament contains ligamentum teres and the para-umbilical vein. Para-umbilical vein. Para-umbilical vein. These are very important derivatives, very important MCQs. Remember, second is lesser omentum. Lesser omentum. Third is the superior and inferior layer of coronary ligament. superior and inferior layers of coronary ligament. Right and left. Right and left triangular ligaments. Superior and inferior layers of coronary ligament, the right and the left triangular ligament. Falciform ligament is a fold of peritoneum which gets reflected from the anterior abdominal wall to the liver. It's a sickle-shaped fold of peritoneum. The peritoneum is the same. The falciform ligament, if you trace up on the liver and then you go up to the diaphragm, that's also fine. Okay, so this is it. Clear? So these are the derivatives of ventral mesogastrium. And now see, what are the derivatives of dorsal mesogastrium? Just have a look. Derivatives of dorsal mesogastrium. Okay, clear? See, now this is the superior layer and that's the inferior layer. You trace them on the right side. What do you get? The right and the left triangular ligaments. I'll show you in the slide. Just have a look at the slide. It will be clear. Just have a look. One moment. जरा इधर सामने रख फोन करो इतना को बोलो okay, just have a look at this slide. Have a look at this slide. Okay, what is this now? Look at this, look at this. Just imagine the liver was here, the liver was here like this, and we've removed the liver, So this is the line of reflection. Look, 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 this is the line of reflection from the diaphragm. It goes to the liver. Just imagine who's in front, anterior abdominal wall. From the anterior abdominal wall, peritoneum comes, it goes to the diaphragm and it gets reflected to the liver. And what is this line of reflection known as? What is this line of reflection known as? This is the superior layer of coronary ligament. Similarly, the peritoneum will come from behind, from the posterior abdominal wall, and it will get reflected to the liver. Look at this. What is this line known as? This is the inferior layer of coronary ligament. You understanding? Now, why is one known as superior and why is one known as inferior? One is at a higher level and one is at a lower level. That's why it is. We had taken a sagittal section. That is why you're seeing like this and like this. This is how we had drawn. But when you see the entire liver is a big organ, no? So the peritoneum will come from the diaphragm and get reflected to the liver. So you'll find a line on the liver. That's the superior layer. And the peritoneum will come from behind and get reflected on the liver. That's the inferior layer. Now, if you join these two layers on the right side, here, this becomes the triangular ligament. This is the right triangular ligament. Right triangular ligament. And what is this on the left side? This becomes the left triangular ligament. Left triangular ligament. Okay. And this big area of the liver is known as the bare area of liver. Bare area of liver. Clear to all of you? Okay, this video is good. I'm getting a very clear picture of this. So this I'm seeing on my screen, eMedico screen. I'm getting a very clear picture. I just use videos. Clear, sir? Now understood this? So this is the superior inferior layer, the right and the left triangular ligaments. All these are derivatives of what? Ventral mesogastrium. Clear to all of you? Okay, now understand this. Tell me now. This keeps on getting outside this. Okay, have a look now. Tell me, what is this now? What is this here? This is the dorsal mesogastrium. That's a dorsal mesogastrium. And who's developing in the dorsal mesogastrium? In the dorsal mesogastrium, what develops is the spleen. The spleen grows in the dorsal mesogastrium, and the spleen now divides the dorsal mesogastrium into two parts. This is one and this is one. This is from the stomach to the spleen. We call this as gastrosplenic ligament. This is the gastrosplenic ligament, and and what is this now known as? This is known as the lino-renal ligament. Lino-renal ligament. So this gastrosplenic, this lino-renal ligaments are derived from what? Dorsal mesogastrium. These are derived from dorsal mesogastrium. Clear to all of you? Now what I'm telling, just understand this. Understand this. Slightly difficult this is. So see this. Okay. Now have a look. Now what I'm telling you, that's the stomach like this. That's the stomach. What's this? Ventral mesogastrium. Who's behind here? That's the dorsal mesogastrium. Just imagine that's a posterior part of stomach and that's the dorsal mesogastrium, and that's a posterior abdominal wall. So in this dorsal mesogastrium, who grows here? That's the spleen. The spleen grows here. Just because the spleen grows here, the dorsal mesogastrium is divided into two parts. One, from the stomach to the spleen, this is what we call as the gastrosplenic ligament. And from the spleen to the kidney, this is what we call as the linorenal ligament. Okay, so that's the gastrosplenic and that's the linorenal ligament. So gastrosplenic and linorenal ligaments are derived from dorsal mesogastrium. And now just understand this. This is the stomach, this is the dorsal mesogastrium, straight back is the dorsal mesogastrium, the spleen is growing here. Now, as the stomach turns, as the stomach goes to the left side, the dorsal mesogastrium also goes to the left side like this. The dorsal mesogastrium goes to the left side. The spleen which was behind now goes to the left side. The spleen has gone to the left side here. So what is this now? Gastrosplenic. And who's this from the spleen behind? That's the linorenal ligament. Incidentally, this gastrosplenic and the linorenal ligament are forming the boundaries of lesser sac. If you can understand this, the gastrosplenic and the linorenal ligament will form the boundaries of lesser sac. Look here once again. This is the dorsal mesogastrium. The spleen grows here. So gastrosplenic and linorenal. And as the stomach turns like this, this dorsal mesogastrium goes to the left side. It goes to the left side. The spleen goes to the left side. This becomes the gastrosplenic and this becomes the linorenal ligament and this becomes the lesser sac. So the gastrosplenic and the linorenal ligament forms the boundaries of what? Lesser sac. Lesser sac. Okay, so this is how the lesser sac is formed. I'll show you a very good slide. Just have a look. See this slide and try to understand this. Okay. Yo, have a look at this. Now the stomach was first like this. Look, the stomach was first like this. Don't see anything else. Just see the stomach is like this. Stomach is like this. And what's this? Dorsal mesogastrium. What's this? Ventral mesogastrium. This is the stomach. That's a dorsal. That's a ventral mesogastrium. Who develops in the dorsal mesogastrium? Spleen. The spleen grows here. Now as the stomach is turning, as the stomach turns, look, the stomach is turned here. The stomach is turned here. The dorsal mesogastrium has gone like this. You understanding? First and to begin with, stomach was like this. This was how the stomach is. That's the dorsal mesogastrium. That's the ventral mesogastrium. Now the stomach turns like this. The dorsal mesogastrium goes like this. Okay, the spleen which was behind goes to which side? The left side. That's the spleen here. So what is this now? What is this? Gastrosplenic. And what is this now? Linorenal ligament. And what is this? What is this space here? That's the lesser sac. That's the lesser sac. Understand? So how is the lesser sac formed? The lesser sac is formed because of the rotation of the stomach, and that's the spleen which is here. So this becomes the gastrosplenic, that becomes the linorenal ligament. The gastrosplenic and the linorenal ligament forms the boundaries of lesser sac. And tell me, the spleen projects into, if you can answer this was an MCQ, spleen projects into which part of the peritoneal cavity? Spleen is intraperitoneal because the spleen is inside the dorsal mesogastrium. Spleen projects into which part of the peritoneal cavity? Look at this. What is this? If that's the lesser sac here, this is a section. This is the horizontal section, transverse section. What is this in front? This is the greater sac. So the spleen is projecting into which part of the peritoneal cavity? Greater sac. You understanding? Spleen projects into the greater sac, but the gastrosplenic and the linorenal ligament are forming the boundaries of what? Lesser sac. Is this clear to all of you? Okay. So now we write the derivatives of ventral mesogastrium. Derivatives of derivatives of dorsal mesogastrium. Ventral is over. Starting with derivatives of dorsal mesogastrium. This is clear to all of you. Derivatives of dorsal mesogastrium. 1. Gastrosplenic ligament. Gastrosplenic ligament. What is a gastrosplenic ligament? Contains. The contents are very important. Contains Mesocolon. Mesocolon, yes, mesocolon does form the boundary of lesser sac. Yes, it forms the boundary of lesser sac. Mesocolon. Just see the slide which I have drawn for the lesser sac. You'll understand the boundaries of lesser sac. Gastrosplenic ligament. What are the contents of gastrosplenic ligament? Short gastric vessels. Short gastric vessels and left gastroepiploid vessels. Short gastric vessels and the left gastroepiploid vessels. Second, linorenal ligament. Linorenal ligament. What does it contain? Splenic artery. This is very important and this you have to know. Splenic artery. And second is the tail of pancreas. It is not hanging. Splenic artery and the tail of pancreas. Okay, splenic artery and tail of pancreas. See how to remember this. Splenic artery. How do you remember the splenic artery lies in what? The splenic artery is a content of what? Linorenal ligament. Splenic artery lies in the linorenal ligament and the branches of splenic artery lies in what? Gastrosplenic ligament. The branches of splenic artery. One which goes up, who's that? Short gastric vessels, and one which goes down. That's the left gastroepiploid vessels. This would lie in what? Gastrosplenic ligament. You understanding? Splenic artery is a content of linorenal ligament and the branches of splenic artery are contents of gastrosplenic ligament. That's how you remember. The tail of the pancreas also lies in the linorenal ligament and this is very important. Why? Because maximum islets of Langerhans are present in tail of the pancreas, and if the tail is gone, the person gets diabetes mellitus. And which part of the pancreas is more prone to cancer? Head of the pancreas. Okay, that we'll see later. Now third derivative of dorsal mesogastrium is the greater omentum. Greater omentum. And fourth is gastrophrenic ligament. Gastrophrenic ligament is from the stomach to the diaphragm. Stomach to the diaphragm. That's a gastrophrenic ligament. Just remember that. Clear? So these are the derivatives of dorsal mesogastrium. Clear to all of you? These are the derivatives of dorsal mesogastrium. See, splenic artery lies in linorenal ligament and the branches of splenic artery, the short gastric and the left gastroepiploid artery lies in the gastrosplenic ligament. Okay, so derivatives of dorsal mesogastrium, one is the gastrosplenic, second is the linorenal, third is the great omentum, and fourth is the gastrophrenic ligament. Just remember it. So this becomes it. Okay, we'll proceed. So that was the development of the stomach. Now we'll proceed, starting with duodenum. Now you know everything about the duodenum. I just have to put this on the paper. Duodenum, you know everything. Okay, starting here with the duodenum. So important organs I'll tell you, and which are asked. Fine. I hope you are able to follow this. Clear? Right. Now, understand this. Duodenum. What is the length of duodenum? 25 centimeters. That's 10 inches. Just listen, don't write anything. Duodenum has got 4 parts. The first part, the stomach continues as duodenum. That's the first part. Second part, third part, and the fourth part. Okay. So that's the first part of the duodenum, second part, third part, and the fourth part of the duodenum. Now, the duodenum, what is the extent of duodenum? It extends from L1 to L3. The first part of the duodenum lies at what vertebral level? L1. The second part extends from L1 to L3. The third part lies at L3 and the fourth part lies at two vertebrae, L2. So first part is at L1, second part extends from L1 to L3, third part is L3, and the fourth part is lies at the level of L2 lumbar vertebrae. Now what all things do you know about the duodenum? Okay, starting with the first part. Listen here. The first part of the duodenum, what is the length? 5 centimeters. 5 centimeters in length. And you remember who's related to the first part of the duodenum is 5 centimeters, out of which half is intraperitoneal. 2.5 centimeters is intra and 2.5 centimeters is retroperitoneal. This I've told you. Who's anteriorly related to the first part of the duodenum? What is this? If you can just tell me what is this related anteriorly to the first part of the duodenum? Remembering this, the body of the gallbladder. The body of the gallbladder, and posterior relations of the first part of the duodenum will be 1. The bile duct, the gastroduodenal artery, and the portal vein. Okay, so that's about the duodenum. First part. What is this part of the duodenum? This part, that's the second part of the duodenum. The second part extends from L1 to L3 vertebral level. Okay, the second part is completely retroperitoneal. And you tell me, who's this crossing the second part of the duodenum here? What's this? This is the transverse colon. So anterior relation of second part of duodenum is going to be what? Transverse colon. And this second part of the duodenum is lying on what? What is this? This is the right kidney. The second part of duodenum lies on the right kidney. So posterior relation of second part of duodenum is the right kidney. Okay, this all I've told you. I'm just trying to recollect, making you recollect things. Which is this part of the duodenum, the third part of the duodenum. What vertebral level does it lie? L3. This third part of the duodenum is completely retroperitoneal. The third part of the duodenum is anteriorly related to what? What are these vessels? The superior mesenteric vessels. And what's this? This is the root of mesentery. This you know. That's the anterior relation. Posterior relation of first part of the duodenum is the this is the right psoas major. And this would be the right ureter, right psoas major, the right ureter, IVC, and the aorta. Okay, so this all you know. We'll put this on the paper, the duodenum. Clear now? So that's very easy now, and this is very important. Okay, so if there's an ulcer in the first part of the duodenum on the posterior wall, which vessel is it going to erode? The gastroduodenal artery. Remember, because gastroduodenal artery lies behind the first part of the duodenum. Clear to all of you? Fine. Starting with the duodenum. Just remember the points which I'm telling you. Remember the points which I'm telling you. Duodenum. What is the length? 25 centimeters. That is 10 inches. 25 centimeters is 10 inches. Okay, starting with the first part of the duodenum. First part of the duodenum. Start. 5 centimeters long. 5 centimeters in length. Second, partially retroperitoneal. Partially retroperitoneal. Okay, 5 centimeters partially retroperitoneal, lies at the level of L1 vertebrae. Lies at the level of L1 vertebrae. Relations anteriorly, body of the gallbladder. Anteriorly is the body of the gallbladder. Posteriorly is the bile duct, gastroduodenal artery, and portal vein. Bile duct, gastroduodenal artery, and portal vein. Okay, second part. How much is the second part? Is 7.5 centimeters in length. First part is 5 centimeters, second part is 7.5 centimeters in length. Completely. I will maintain the same sequence so it is easy to remember. So these are the MCQs which are asked. Just focusing on the important things. completely retroperitoneal, completely retroperitoneal, extends from L1 to L3 level, extends from L1 to L3 level. Fourth, extends from L1 to L3 anteriorly, transverse colon, posteriorly, right kidney. Anteriorly is the transverse colon, posteriorly is the right kidney. Okay, understand all these relations. Superior relations of first part would be the epiploic foramen. Superior relation of the first part, if you want to know, that's epiploic foramen. Okay, you know epiploic foramen ka inferior boundary is formed by the first part of duodenum. Clear? So third part. What is the length? 10 centimeters. Length. 10 centimeters in length. Completely retro completely retroperitoneal. Third, lies at L3 vertebral level. Lies at L3 vertebral level. Anteriorly, superior mesenteric vessels, root of mesentery, anteriorly is the superior mesenteric vessels and root of mesentery, posteriorly, right psoas major, right ureter, right psoas major, right ureter, IVC, aorta. Fundus of the gallbladder is mainly related to transverse colon. Okay. Uncinate process will be related to the third part. Superiorly is uncinate process. But these are the important relations which are asked. And last, fourth part. Length 2.5 centimeters. 2.5 centimeters, partially retroperitoneal. Okay, length is 2.5 centimeters, partially retroperitoneal. Lies at L2 level. Nutcracker sign is the compression of left renal vein between the superior mesenteric artery and the aorta. Okay, so partially retroperitoneal lies at the level of L2 vertebrae. No specific relations here. Clear to all of you? What is the blood supply? Blood supply of duodenum. Now, duodenum partly is derived from foregut and duodenum partly is derived from midgut. Okay, no? So, part of the duodenum above the opening of bile duct. Who supplies this? The superior pancreaticoduodenal artery. The part of the duodenum above the opening of bile duct is supplied by superior pancreaticoduodenal artery, and the part of the duodenum below the opening of bile duct is supplied by inferior pancreaticoduodenal artery. Okay, so above the opening of bile duct, is superior pancreaticoduodenal. superior pancreaticoduodenal, and below it is inferior vein gets compressed, the left renal vein gets compressed. I've explained everything, you people have to pay attention, okay? Inferior pancreaticoduodenal artery, inferior pancreaticoduodenal artery, inferior pancreaticoduodenal artery. Renal artery gets compressed, the left renal artery and the left renal vein gets compressed between the superior mesenteric artery and the aorta. I'll show you the slide, Okay, so that's about the duodenum. Clear to all of you? The duodenum. Okay. So that's about the duodenum. Blood supply of the stomach is easy. Just one moment, I'll show that slide. Now someone is asking, the small intestine is intraperitoneal, then how is the duodenum retroperitoneal? Now what do I answer, you tell me? Small intestine is intraperitoneal, then how is the duodenum retroperitoneal? I have explained everything. When I explain, please don't sit and chat, please don't sit and talk to each other, and then don't ask me such doubts. Okay, clear to all of you? Okay, look at this now. What is this? Look at this. That nutcracker sign, who's asking me? What is this now? What is this? This is the left renal vein. That's the left renal vein. You can see that's the left renal vein here. That's the left renal vein. And what is the IVC is lying on which side? Right side. IVC is lying on the right side, right? IVC is lying on the right side. Just one moment. IVC is lying on which side? Right side. IVC is lying on the right side. So which renal vein will be longer? Left. The left renal vein is longer. And this left renal vein lies between what and what? It lies between the superior mesenteric artery and the aorta. Okay, so the left renal vein lies between the superior mesenteric artery and the aorta. And the left renal vein gets compressed between the superior mesenteric artery and the aorta. Okay. So that's how it is. Fine. Okay. Now, fine. You people are talking a lot. Now, last lecture I'll tell someone else to take. Okay. Because you people don't listen. Last lecture someone else will take. Let them take the lecture. So now I'm not bothered now. I've done my job. I'll tell the head office for someone else to take the lecture. What is left, someone else will take for you. Starting with the pancreas. So those fools who are sitting in the lecture now, they will also understand. Okay. Have a look at this. Starting with the pancreas here. Pancreas. Okay, so pancreas. Now, what are the parts of the pancreas? What are the parts of the pancreas? Pancreas has got a head, neck, body, and tail. Look here. That's the head, neck, body, and tail of the pancreas. And what is this process the pancreas has? Uncinate process. That's the uncinate process of pancreas. So, what are the parts of the pancreas? Head, neck, body, and tail. So, duodenum I've done. I'm starting with the pancreas. Head, neck, body, and tail of the pancreas. And this process is the uncinate process. Okay. Please don't sit and disturb. I'm telling you, if you sit and chat now, I'll straight away stop teaching. I'm telling you, I'll straight away stop teaching, and then someone else will come and teach. Then I'm not going to teach. Okay, I'm telling you beforehand. So, okay, now I'm just finishing this topics because I can't just leave in between. Fine. So, what are the parts of the pancreas? This is the head, neck, body, and tail of the pancreas. And what is this? Uncinate process. Fine. So, pancreas starts from the right side and goes to the left side. So the pancreas has got many relations, plenty of relation. Very important pancreas. I'm starting here, just have a look. The pancreas is lying within what? Within the duodenum. The sea of the duodenum lies the pancreas. Okay, starting with the head of the pancreas. We've got the duodenum. The duodenum has come down. The duodenum has come down. Otherwise, the duodenum would be slightly higher to the pancreas. Okay, but still, you've got the duodenum. A part of the duodenum would be related to the pancreas, the first part of the duodenum, and something else who's related to the head of the pancreas. What's that? The transverse colon. Okay, so what are the anterior relations of the head of the pancreas? Starting here with the pancreas, starting with the anterior relations of the head, starting with the head of the pancreas. Okay, head of the pancreas, anterior relations. Anterior relation is the first part of duodenum, and the transverse colon. First part of the duodenum and the transverse colon. Okay, so that becomes the head of the pancreas, anterior relation. First part of the duodenum and the transverse colon. Posterior relations of the head of the pancreas. Look at this now. This is done. Finish this. Anterior relations of the head of the pancreas is the first part of the duodenum and the transverse colon. And the posterior relations of the first part. What is it going to be? Posterior relations of the first part. See the slide and tell me now. This is difficult, just try to understand this. Okay, now which kidney is this? This is the right kidney. And who's this on the right kidney? What is this on the right kidney? That's the second part of duodenum. That's the second part of the duodenum lying on the kidney. And tell me now, what is this going to be? This is going to be the head of the pancreas here. This is going to be the head of the pancreas. You following? So what are the posterior relations of the head of the pancreas? Posterior relations of the head of the pancreas is 1, IVC. Second, the right renal vein. Third, what is this? If you can just tell me, look, what is this? That's the right crus of the diaphragm. The left crus of the diaphragm forms a stomach bed. It forms a stomach bed. And this right crus of the diaphragm would be lying behind the head of the pancreas. And you remember, this is the second part of duodenum, and there was a duct which was coming and opening in the second part of the duodenum. Who's that? That's the bile duct. Bile duct opens in the second part of the duodenum. So this becomes the posterior relations of the head of the pancreas. See how to remember this. This is the duodenum. Just concentrate. I will not repeat this. I'm not looking at the chat box at all. If you are interested, concentrate on the lecture. Otherwise, forget it. I'm not looking at the chat box. I'm not looking your comments at all now. Okay. I'm just teaching. If you are following, you listen. Now, what is this now? This is the second part of the duodenum. Okay. That's the second part of the duodenum here. Now, what is this? This is the head of the pancreas. That's the head of the pancreas. So, posterior relations of the head of the pancreas is going to be 1 here, 1. This is the IVC. Second is the right renal vein. Third is the right crus of the diaphragm. And third is a duct which comes and opens in the second part of the duodenum. What's that? Bile duct. Okay, that's how it is. So starting with posterior relations of the head. Posterior relations of the head. Starting with the posterior relations of head. Anterior relations of the head are clear to you. One is the first part of the duodenum and the transverse colon. Posterior relations of the head. One, IVC, IVC. And second, the right renal vein, right renal vein. Third, the right crus of the diaphragm, right crus of the diaphragm, and fourth is the bile duct. Right crus of the diaphragm and fourth is the bile duct. Okay, so these are the posterior relations of the head of the pancreas. And these slides you have to keep on looking at. You have to see the slides continuously, only then you'll be able to follow this. You have to revise the slides again and again. So then the moment you see the slides, you'll be able to understand the relations. This becomes the posterior relations of the head of the pancreas. Difficult is pancreas to understand. There are plenty of relations for the pancreas. Look at this once again. This is the head of the pancreas. So anterior relations of the head will be what? This is the first part of the duodenum. And what is this? This would be the transverse colon. So that's the anterior relations of the head. Posterior relations of the head. Look here once again. Posterior relations of the head of the pancreas. That's the duodenum here. This is going to be the head of the pancreas. So posterior relation is going to be one, IVC. Second is the right renal vein. Third is the right crus of the diaphragm. And the fourth one is the bile duct. Bile duct. The fourth is the bile duct. Okay. So this becomes the head of the pancreas. Coming to the next part of the pancreas is this. The next part of the pancreas is going to be the neck of the pancreas. Neck of the pancreas. So now you tell me, if that's the first part of the duodenum, what would be just before the first part of the duodenum? Just before the first part. You tell me, this is the first part of the duodenum and that's the stomach here. So which part of the stomach would be coming here and be related to the neck of the pancreas? This is the pylorus of the stomach. Pylorus. So anterior relations of the neck of the pancreas is going to be the pylorus of the stomach. Pylorus. Okay. And posterior relations of the neck, I've told you. Two veins. Who's in the upper part? Portal vein. And the vein which is coming from this on the uncinate process. What's that? Superior mesenteric vein. Comes and goes behind the neck, and there's someone who's coming from here, that's the splenic vein, and together they join to form what? Portal vein. So behind the neck of the pancreas, we had drawn the slide. There are two veins, portal vein in the upper part and the superior mesenteric vein in the lower part. Okay, so that becomes the relations of the neck of the pancreas. Have a look. Posterior relations of the starting with neck of the pancreas. Anteriorly, pylorus of the stomach. Anteriorly is the pylorus of the stomach. Posteriorly, portal vein in the upper part and superior mesenteric vein in the lower part. Superior mesenteric vein in the lower part. This is clear to all of you. So posteriorly is the portal vein in the upper part and the superior mesenteric vein in the lower part. Okay, clear to all of you. So that becomes the relations of the neck of the pancreas. Next would be the body of the pancreas. Next would be the uncinate process. I'll first start with the uncinate process. Uncinate process of the pancreas. Just have a look here. Okay. Now, on the uncinate process, who lies on the uncinate process? The superior mesenteric vessels. The superior mesenteric vessels lies on the uncinate process. The superior mesenteric vessel lies on the uncinate process of the pancreas. Just wait, let this be clear. Let this image become clear. Okay, who lies on the uncinate process is the superior mesenteric vessels, and who's lying behind the uncinate process? Look at this. What is this big artery coming from, going back? That's the aorta. So you can just write this down. I'm not writing this. Uncinate process. Start with the next. Uncinate process. Anteriorly superior mesenteric vessels. Just write this down. Uncinate process. Anteriorly is the superior mesenteric vessels. Superior mesenteric vessels. Posteriorly, aorta. Posteriorly is the aorta. Uncinate process. Anteriorly is the superior mesenteric vessels. Posteriorly is the aorta. Fine. And now this superior mesenteric vessels lie on the uncinate process. One moment, just understand this now. This is slightly difficult. Just try to understand this. Okay, this superior mesenteric vein lies on the uncinate process. This superior mesenteric artery lies on the uncinate process. And now they'll be crossing what? They'll be crossing what? The third part of duodenum. Third part of duodenum. You remember the anterior relation of third part of duodenum is what? Superior mesenteric vessels. Superior mesenteric vessels. And who's lying behind the third part in this case? This is the aorta. That's the aorta which is lying behind the third part of the duodenum. And the third part of the duodenum can get compressed between what? The superior mesenteric artery and the aorta. The third part of the duodenum can get compressed between the superior mesenteric artery and the aorta, and this is what we call as the SMA syndrome. SMA syndrome. Superior mesenteric artery syndrome. That's compression of third part of duodenum. Compression of third part of the duodenum between the superior mesenteric artery and the aorta. Compression of the third part of the duodenum between the superior mesenteric artery and the aorta. Clear? So that's the compression of the third part of the duodenum between the superior mesenteric artery and the aorta. Uncinate process posterior relation is aorta. Uncinate process का posterior relation is aorta. And what was that other syndrome? Nutcracker sign. Nutcracker sign is the compression of the left renal vein. Compression of the left renal vein between superior mesenteric artery and aorta. Compression of the left renal vein between the superior mesenteric artery and the aorta. Okay, so this is SMA syndrome, this is Nutcracker sign. So between the superior mesenteric artery and the aorta lies the left renal vein, lies the third part of duodenum. Left renal vein. Clear to all of you? So that's about the... Okay. So now, anterior relation of the uncinate process is clear to all of you. Anterior relation of uncinate process is going to be the superior mesenteric vessels. The posterior relation of uncinate process is the aorta. Look at this, the aorta will go back, and the posterior relation of the uncinate process is the aorta. Clear to all of you? Clear? Now see this, just understand what I'm telling you. Have a look. Now, this superior mesenteric artery and the vein, they lie on the uncinate process. The same superior mesenteric artery and the vein would cross what? The third part of duodenum. So anterior relation of third part of the duodenum is what? Superior mesenteric vessels and the root of mesentery. This you know, root of mesentery. Now understand what I'm telling you. That's the superior mesenteric vein, lies on the uncinate process. Now this superior mesenteric vein goes up, lies behind what? The superior mesenteric vein is going up. It would lie behind what? The neck of the pancreas. And what is this vein coming from behind the body of the pancreas? Who's this vein coming from behind the body? That's the splenic vein. And what would this vein be now? What will this vein be? Portal vein. Portal vein. You understanding? So behind the neck of the pancreas, in the upper part is the portal vein, and in the lower part is what? Superior mesenteric vein. Is this relation clear to all of you? In the upper part, that's the portal vein, and in the lower part is superior mesenteric vein. Okay, so these are the posterior relations of the neck of the pancreas. Okay. Now tell me, this is the superior mesenteric artery. If you trace the superior mesenteric vein up, you're right behind the neck of the pancreas. If you trace the superior mesenteric artery up, you're right behind the body of the pancreas. So the superior mesenteric artery will arise behind what? Look at this. The superior mesenteric artery will arise behind the body of the pancreas and then come to lie on the uncinate process. Just understand this, and this is slightly difficult to understand. See if you can understand this. Yeah, just have a look. Now what I'm telling you is, look, this is the body of the pancreas and this is the uncinate process. This is the body and this is the uncinate process. The superior mesenteric artery arises behind the body of the pancreas and then comes to lie on the uncinate process. Okay, the superior mesenteric artery arises behind the body and lies on the uncinate process, whereas the superior mesenteric vein lies on the uncinate process, and if you trace the vein up, it's behind the neck of the pancreas. I hope I'm clear with this. Okay, this is very important. Be clear about all these relations. Clear? Look at this. So the superior mesenteric vein lies on the uncinate process, then the superior mesenteric vein goes behind the neck of the pancreas, whereas the superior mesenteric artery lies on the uncinate process, and the superior mesenteric artery, if you trace it up, it goes behind the body of the pancreas, and the superior mesenteric artery arises from what? The superior mesenteric artery arises from the aorta. Okay, so who will be behind the body of the pancreas? The aorta, with the origin of superior mesenteric artery. So behind the body of the pancreas is going to be aorta and the superior mesenteric artery. Clear? Understand this now? Relations of the body of the pancreas. Now starting with body of the pancreas, you're clear now? Look here, anterior relations of the neck of the pancreas was what? Neck, pylorus of the stomach. Posterior relations of the neck of the pancreas was superior mesenteric vein in the lower part and the portal vein in the upper part. Uncinate process, anterior relation was superior mesenteric vessels. The posterior relation was aorta, the relation of uncinate process. Now starting with the body of pancreas, have a look. This is slightly difficult to understand. Body of the pancreas. Here on the superior border of the body, what is this artery here? Splenic artery. Anterior to the body, what's this? What is this? Who's this? This is the transverse colon. Anterior to the body of the pancreas would be the transverse colon. Okay, now starting with body of the pancreas. Body of the pancreas. Body of the pancreas, superiorly, splenic artery, anteriorly, transverse colon, starting with the posterior relations of the body, of the pancreas. Understand this now? Understand this, posterior relations of the body of pancreas. Okay. Posterior relations of the body of pancreas. Now look, what have we done here? The pancreas goes like this. The pancreas actually goes like this. Pancreas goes like this. Now, okay, look here. The pancreas actually goes like this. Now, what have we done here? The pancreas goes like this. Now, what have we done? We have taken the pancreas down. And we are seeing the posterior relations of the body of pancreas. Okay, now we are seeing the posterior relations of the body of pancreas. Have a look. Understand this first. The posterior relations of the body of pancreas. One. Easy things I'll tell you first. One. is this. The pancreas goes like this, look. The pancreas goes like this and the spleen is right here. So posterior relations of the body of the pancreas would be 1. The left kidney, the left suprarenal gland, left kidney, the left suprarenal gland. What is this now? That's the left renal vein, the left crus of the diaphragm. You remember the left crus of the diaphragm was forming the posterior relations of the stomach. The left crus of the diaphragm also goes down and forms the posterior relations of the body of the pancreas, also forms the posterior relation of the body of the pancreas. Okay, so what are the posterior relations of the body of the pancreas? 1 is the left kidney, 2nd is the left suprarenal, 3rd is the left renal vein. The artery we don't take in the relation because the artery lies exactly behind the vein. It is drawn as if you're looking at like this. Okay, so we do not take the artery. The artery is right behind the vein here. Okay, so we take the left renal vein, the left crus of the diaphragm, the aorta with the origin of superior mesenteric artery. Look, this is what I was telling you. Origin of the superior mesenteric artery is behind the body of the pancreas, and this superior mesenteric artery from behind the body of the pancreas now comes to lie on uncinate process. It now comes to lie on the uncinate process. Following this, so now look here, what are the posterior regions of the body of pancreas? In sequence, I'll tell you. 1. Aorta with the origin of superior mesenteric artery. 2nd is the left renal vein. 3rd is the left crus of the diaphragm. 4th, the left kidney. 5th is the left suprarenal. And there's a vein throughout the body of the pancreas. What's that? The left renal vein. Okay. I'll show you the slide once more. Starting with body of the pancreas. Superior to the body of the pancreas is the splenic artery. Anterior to the body of the pancreas is the transverse colon. Okay. Now, splenic artery is superior. Splenic vein is behind the body of the pancreas. Clear? Now, posteriorly, the relations are 1. Aorta with the origin of superior mesenteric artery. Aorta with the origin of superior mesenteric artery. 2nd, left renal vein. 3rd, left crus of the diaphragm. Left kidney. Left suprarenal. And 6th is the splenic vein. Okay, so this becomes the clear to all of you. Anterior relation would also be stomach. Yes. Anterior relations of the body. Anterior relation, you've taken transverse colon, and the second one would be stomach also. Stomach. Yes, stomach. The stomach bed, pancreas comes. In the stomach bed, pancreas comes. So anterior relation of the body of the pancreas is going to be transverse colon and the stomach. Okay, that's good. So posterior relations of the body of the pancreas. Aorta with the origin of superior mesenteric artery, the left renal vein, the left crus of the diaphragm, the left kidney, the left suprarenal, and the splenic vein. Okay, clear to all of you. Splenic vein. I've written it, splenic vein. Left kidney, then you have left suprarenal gland and the splenic vein. Yes, left suprarenal gland and the splenic vein. Artery we don't take in the relation because the artery is right behind the vein. Gonadal vein is below the renal vein. Okay, fine. That's it. So that's about the body of the pancreas. So you're clear with the head of the pancreas, neck of the pancreas, uncinate process, the body of the pancreas. The last is the tail of the pancreas. Tail of the pancreas enters the hilum of the spleen. lies in the linorenal ligament. Lies in the linorenal ligament. You get MCQs on all this. MCQs on the relations on the body of the pancreas. Okay, understand this relation first. Then I put the MCQs for you. So that's about the tail of the pancreas. Enters the hilum of the spleen. Lies in the linorenal ligament. Clear to all of you? Yes. Right. So that's about the pancreas. Now understand this. Okay, you want an MCQ? Have a look at this. Yep, answer this. Answer this. All the following statements about relations of pancreas are true except okay. Yes, first part of the duodenum lies posterior to the head. Yes. So right renal vein lies posterior to the head. Yes, that's right. Right renal vein lies posterior to the head. That's correct. Superior mesenteric artery lies anterior to the uncinate process. Yes. First part of the duodenum, that's wrong. Superior mesenteric vein lies behind the neck. That's right. Okay, clear to all of you. So that's about the pancreas. Now one more thing you have to understand now. Development of pancreas. Understand this now. Okay. Understand this. Development of pancreas. Okay, I start. So clear with the relations of pancreas, clear with the relations of the duodenum. This is a very important topic, very important MCQs. Okay, starting with development of pancreas. Another very important MCQs on development of pancreas. Have a look. I'll start. Now that's the foregut and that's the midgut. Okay, that's the foregut, that's the midgut. At the junction of foregut and midgut, have a look at this. This is the foregut, this is the midgut. At the junction of foregut and midgut, we get a small diverticulum here. What is this diverticulum known as? The hepatic diverticulum. Hepatic diverticulum, and this hepatic diverticulum will be growing towards. I've told you this hepatic diverticulum will be growing towards the ventral mesogastrium, and this hepatic diverticulum forms what? The lever. It forms the lever, hepatic diverticulum, and it gives a small diverticulum for the gallbladder. What do you call this diverticulum as? The cystic diverticulum. Cystic. Okay. Now this hepatic diverticulum is growing towards the ventral mesogastrium, and here it divides the ventral mesogastrium into two parts. One, the falciform ligament, and the lesser omentum. Okay. So that's about the hepatic diverticulum. Now, at the junction of the hepatic diverticulum and the gut, you get a small bud here. Look at this. What is this bud? This is the ventral pancreatic bud. Okay. This is the ventral pancreatic bud. Okay, look at this. This is the ventral pancreatic bud. At the junction of the hepatic diverticulum and the gut, you get this ventral pancreatic bud. Exactly at the opposite side, you get another bud here. What's this? This is the dorsal pancreatic bud. Dorsal pancreatic bud. That means this pancreas is an outpouching. It is derived from the GIT. This pancreas is therefore what in origin? Endodermal in origin. You're clear? The liver, the pancreas, all this would be endodermal in origin. So now see here, what is this bud? This is the ventral pancreatic bud. Just 5 minutes. This is the ventral pancreatic bud and this is the dorsal pancreatic bud. Now this ventral pancreatic bud will be going from backside. It goes from behind the pancreas. It comes and joins with what? The dorsal pancreatic bud. It comes and joins with the dorsal pancreatic bud. Look at that. The ventral pancreatic bud goes from backside, goes and joins with the dorsal bud. But sometimes half of the ventral bud goes from back, half of the ventral bud comes from front. Look, half of the ventral bud comes from front, and this type of pancreas is going to encircle the duodenum, and this is what we call as annular pancreas. Okay, so how is annular pancreas formed? Annular pancreas is caused due to improper migration of which bud? Ventral pancreatic bud. Just remember, only ventral bud is going to migrate. The ventral bud goes from backside, joins with the dorsal bud, and this is what is going to form the pancreas. Okay, but sometimes half of the ventral bud goes from back, half of the ventral bud comes from front, and this type of pancreas is going to encircle the duodenum, and this is what we call as the annular pancreas. Okay, so annular pancreas occurs due to defective migration of, your answer is ventral pancreatic bud. Okay, now sometimes this ventral bud and the dorsal bud do not join with each other, they do not fuse with each other, and in this case we get a divided pancreas, a pancreatic divisum. So pancreatic divisum occurs due to non-fusion of the two pancreatic buds. Understanding, non-fusion of the two pancreatic buds results in pancreatic divisum. Now you have to know what is derived from the dorsal bud and what is derived from the ventral bud. Just have a look at this. The dorsal pancreatic bud forms what? The upper part of the head, neck, body, and the tail of the pancreas. The ventral pancreatic bud, it forms what? The lower part of the head and the uncinate process. So the dorsal pancreatic bud forms the upper part of the head, neck, body, and tail of the pancreas. The ventral pancreatic bud forms the lower part of the head and the uncinate process. Okay, so this is what you have to know. Just one more thing in the development of pancreas. What is this duct of? Look, what is this duct of? This is the duct of dorsal bud. That's the duct of dorsal bud. Discussing the development of pancreas. Okay, so pancreas is derived from the GIT. There are two buds. One is the ventral pancreatic bud, one is the dorsal pancreatic bud. The ventral bud goes from backside. The rest of the things you have heard. The ventral pancreatic bud goes from backside, comes and joins with the dorsal bud. Now you have to know what is the dorsal pancreatic bud form and what is the ventral pancreatic bud form. Okay, so the dorsal pancreatic bud, what does it form? The upper part of the head, neck, body, and tail of the pancreas. And the ventral pancreatic bud forms the lower part of the head and the uncinate process. So that's how the pancreas is formed. Now you tell me, what is this duct of? Just one moment. What is this duct of? This is the duct of dorsal bud. That's the duct of dorsal bud. And what is this duct of? That's the duct of ventral bud. So one is the duct of dorsal bud, one is the duct of ventral bud. How is the main pancreatic duct formed? The main pancreatic duct is derived from the duct of the dorsal bud, the duct of the ventral bud, and the anastomosis between them. Look at this. That's the anastomosis. So the main pancreatic duct is derived from the duct of the dorsal bud, the duct of the ventral bud, and the anastomosis between them. That's the main duct. And then what is this going to form? This is going to form the accessory pancreatic duct. Accessory pancreatic duct is derived from the duct of, have a look at this slide, it will be clear. Look at this. So what is this duct of? This is the duct of the dorsal bud, and that's the duct of the ventral bud. Clear? So how is the main pancreatic duct derived from? The main pancreatic duct is derived from the duct of the dorsal bud, the duct of the ventral bud, and the anastomosis between them. And this will become what? The accessory pancreatic duct. This is derived from the duct of dorsal bud. Duct of dorsal bud. Is this clear to all of you? The pancreas is clear. We'll start with the development of pancreas. Yeah. Okay, I'll start with the development of pancreas. So the gross of the pancreas is clear to you know, the head, neck, body, and tail of the pancreas, the uncinate process. Okay, I'll just quickly go through that pancreas once again. Okay, fine. We'll start with the pancreas. We'll start with the development of pancreas. Start development of pancreas. Development. This is very important. Plenty of MCQs on the development of pancreas. Start. The dorsal pancreatic bud forms. Dorsal pancreatic bud forms upper part of the head, neck, upper part of the head, neck, body and tail of the pancreas. Okay, upper part of the head, neck, body and tail of the pancreas. Ventral pancreatic bud forms. Ventral pancreatic bud forms lower part of the head, and uncinate process. Lower part of the head and the uncinate process. Okay, lower part of the head and the uncinate process. Next, annular pancreas. Annular pancreas occurs due to improper migration of ventral pancreatic bud. Annular pancreas occurs due to improper migration of the ventral pancreatic bud. Okay, this is an MCQ. Next, non-fusion of the two buds results in pancreatic divisum. It's a divided pancreas. So non-fusion of the two buds results in pancreatic divisum. Okay, clear to all of you? Now, this is it. Just one last thing about the pancreas. Pancreas is a very, very, very important topic. You tell me, if the pancreas has got a cyst, and if the cyst breaks anteriorly, if the pseudopancreatic cyst breaks anteriorly, where would it rupture into? Answer this. Pseudopancreatic cyst, if it breaks anterior to the pancreas, what will it break? Yes. Answer this. A cyst of the pancreas, if it breaks in front, anterior to the pancreas, what is it going to rupture? Anterior, I'm saying anterior. Anteriorly, if it breaks, what is it going to? Lesser sac. Yes, lesser sac. You're understanding lesser sac. See, this is so nice. Understand lesser sac. Lesser sac. What will the boundaries of lesser sac? Just see the slide which you have drawn, and all the slides that I've told you to draw are extremely important slides. You've drawn those slides. So lesser sac boundary was what? One was the less omentum, starting from the liver, the less omentum, the stomach, and then the greater omentum. And again, the posterior boundary of lesser sac would be formed by the greater omentum and all the structures which are forming the stomach bed. So that was the lesser sac. You just try to visualize the slide that we have drawn. Okay. If the pancreas cyst is going to break in front, it would enter into the lesser sac. Understanding? Fine. Okay, now starting with main pancreatic duct. Main pancreatic duct, or this is known as the duct of Wirsum. Main pancreatic duct or the duct of Wirsung. This you must be knowing. The main pancreatic duct is known as the duct of Wirsung, formed by ducts of dorsal bud, ventral bud, and anastomosis between them. Clear, no? So the main pancreatic duct is derived from the duct of the dorsal bud, ventral bud, and the anastomosis between them. Opens at major duodenal papillae. Opens at the major duodenal papillae 8 to 10 centimeters from the pylorus. Opens at the major duodenal papillae 8 to 10 centimeters away from the pylorus. Accessory pancreatic duct. Accessory pancreatic duct, also known as the scroll that. Accessory pancreatic duct, also known as the duct of Santorini. Duct of Santorini, formed by ducts of dorsal bud, duct of dorsal bud, opens at minor duodenal papillae, opens at the minor duodenal papillae 6 to 8 centimeters from the pylorus. Okay, that's it. Opens at the minor duodenal papillae 6 to 8 centimeters from the pylorus. Is this clear to all of you? I'll scroll that. So this is about the pancreas. I've told you everything about the pancreas. So that's it. Okay, so that's a complete pancreas. Clear? Any doubt with the pancreas? Just see if you can just try to correlate that. Okay, I'll quickly go through this pancreas once for you. Chalo. Okay. I'll start once again with the pancreas. Quick, just a quick revision I'll give you about the pancreas. We'll start. Here we are with the pancreas. Yeah. Now this is starting with the abdomen once again. That's the problem. And here we are with the pancreas once again. Now tell me. Quickly, I'll just go through this first. Just have a look at the slide and quickly you tell me. Here we are. Start with the pancreas. Here. Pancreas is retroperitoneal, but what is covering the anterior aspect of the pancreas? The lesser sac, no. The lesser sac ka posterior boundary, the anterior boundary of lesser sac is formed by what? To see the slide which we have drawn. The posterior boundary of lesser sac, the posterior wall of lesser sac will be formed by the pancreas. Understand? So if the pancreas ruptures in front, it is right going to enter into the lesser sac. Understand? Just see the slide which you have drawn for the lesser sac. I'll show you this. Okay, I'm just starting with the pancreas once again. Just have a look. This is so nice. Look, I'll start. That's the head of the pancreas. And what is the anterior relations of the head of the pancreas? One is the first part of the duodenum and the second one is going to be the transverse colon. Okay, now posterior relations of the head of the pancreas. What is this? Posterior relations of the head of the pancreas. Here we are. See the slide once again. Now, this is the right kidney, and who's this? That's the second part of the duodenum, second part. So we just place the head of the pancreas here like this. So see the slides again and again, you'll be perfect with that. So what are the posterior relations of the head of the pancreas? One, IVC. Second is the right renal vein, right renal vein. Again, artery we do not take in the relation because the artery lies right behind the vein. If you see the relations of the hilum of the kidney, how's that? It's vein, artery, pelvis, vein, artery, pelvis. So the artery is right behind the vein. Okay, it's not seen like this. He's drawn as if you're looking from up like this. So what are the posterior relations of the head of the pancreas? One is IVC, second is the right renal vein, third is the right crus of the diaphragm, and fourth is this duct which opens in the second part of the duodenum. That's the bile duct. Bile duct, clear? Now coming to the next one, the neck of the pancreas. Look, if that's the first part of the duodenum here, who would be just below this? That's the stomach which comes like this. That's the stomach which comes like this. And what is this part of the stomach? The last part of the stomach is known as the pylorus. So anterior relation of the neck of the pancreas is going to be pylorus of the stomach. And the posterior relations of the neck of the pancreas, look, what is this vein here? That's the superior mesenteric vein in the lower part. And who's this vein coming from behind the body of the pancreas? The splenic vein. And what would this vein be? Portal vein. So behind the neck of the pancreas would be the portal vein in the upper part and the superior mesenteric vein in its lower part. Okay, that's it. Now coming to the uncinate process, the anterior to the uncinate process is going to be what? The superior mesenteric vessels, and the same superior mesenteric vessels are anteriorly related to the third part of duodenum. Okay, the posterior relation of the uncinate process is going to be the aorta. That's the aorta which will go straight up, and that forms the posterior relations of the uncinate process. Clear to all of you? Now coming to the body of the pancreas, the anterior relations of the body would be, one is this transverse colon which comes here, and second was the stomach here, stomach. So the anterior relations of the body would be the stomach and the transverse colon. The superiorly, who's related to the body of pancreas, what's that? The splenic artery. Superiorly would be the splenic artery, and posterior relations of the body of the pancreas would be, yeah. See the slide, posterior relations of the body of pancreas. Once again, have a look. The body of the pancreas goes like this, it goes like this. So what have we done? We've reflected the pancreas down. And now what is the posterior relations of the body of the pancreas? In sequence, one, aorta with the origin of superior mesenteric artery. Once again, I'm telling you, the superior mesenteric artery arises behind the body of the pancreas. The superior mesenteric artery then comes to lie on uncinate process. It's behind the body and then it comes to lie on the uncinate process. So what are the posterior relations of the body? One is the superior mesenteric artery, aorta with the origin of superior mesenteric artery. Second is the left renal vein. Third is the left crus of the diaphragm, the left kidney, the left suprarenal, and the vein, long vein behind the body of the pancreas is the splenic vein. Fine, that's it. And last is the tail of the pancreas. The tail of the pancreas enters into the hilum of the spleen. It lies into what? The lienorenal ligament. It should be perfect pancreas. Okay, clear to all of you. That's it. That's about the pancreas. Now starting with the next organ, spleen. I'm finishing the foregut first. I'll finish the foregut for you. Okay. So we'll finish the foregut and then you take a break. Then I start with the midgut. Okay. Starting with the foregut. Starting with the spleen. So foregut organs I'm finishing. Starting with the spleen now. Spleen. Just the important things of the spleen I'm telling you. Abdomen is very nice to understand. You just have to understand the relations and just go through it. Then you'll enjoy studying it. How the pancreas, how the duodenum, how the spleen, and how they are related to each other. Spleen. You remember this formula for spleen? 1, 3, 5, 7, 9 and 11. 1, 3, 5, 7, 9, 11. Blood supply of pancreas, these are the pancreatic branches of the splenic artery. Splenic artery runs on the superior border, then the pancreatic branches of splenic artery, the superior pancreaticoduodenal, the inferior pancreaticoduodenal. They all supply the pancreas. Okay. That's it. Blood supply of the pancreas is the pancreatic branches of splenic artery, the superior pancreaticoduodenal which comes from up, and the inferior pancreaticoduodenal. That's it. That's not much important. Okay, that's the spleen. And that's the formula of the spleen. Some important points of the spleen I'll give you, what is important and what is very much asked. Spleen. So what are the dimensions? We'll start. Dimensions of the spleen. Yes, it's 1 inch, 3 inch, 5 inch. It's 5 inches in length. 5 inches in length. 3 inches in breadth. And 1 inch in thickness. So 5 inches in length, 3 inches in breadth, and 1 inch in thickness. Okay. Next is 7 ounces in weight. 7 ounces in weight. 7 ounces is roughly 250 grams in weight. Okay, 250 grams in weight. And what is 9 and 11? It is between the 9th and the 11th ribs. Spleen is between the 9th and the 11th rib. The long axis is directed along. The long axis is directed along the 10th rib. So spleen is present between the 9th and the 11th rib. It lies between the 9th and the 11th rib. But if you draw a long axis to the spleen, it passes through the 10th rib. Okay. So that's how you remember the spleen. 1, 3, 7, 9, 10, 11. Something else now, something else which is important. Now, spleen is not placed like this vertically. The spleen is not vertically. The spleen is slightly tilted here. The spleen is tilted. If you draw a horizontal line here, how much angle does the spleen makes with the horizontal? If you draw a horizontal line, the spleen makes an angle of. So these are some very important points. Spleen makes an angle of 45 degrees with the horizontal plane. Spleen makes an angle of 45 degrees with the horizontal plane. Okay, 45 degrees, it's like that, 45 degrees with the horizontal plane. Now, if you see the spleen shows notches. Notches can be present along any border of the spleen. Spleen has got 3 borders, superior, inferior border, and one is on the medial side. So the spleen will show notches like this. What does the notches indicate? Small notches. And what does the notches indicate? That the spleen has developed from small lobules. You know, there are small lobules which develop in the dorsal mesogastrium, and these lobules are going to fuse. And where they fuse, you get notches. So generally any border of the spleen can be notched, but it is said that the superior border is notched. Superior border is notched. Look, notches can be present along any border of the spleen, but generally the superior border is said to be notched. Okay, just remember this. Projects into, I just told you the spleen projects into. If you can answer this, spleen projects into which part of the peritoneal cavity? Greater sac. I've shown you this. Okay, it projects into the greater sac. Greater sac. Spleen projects into the greater sac. Clear to you? Commonest site of accessory spleen. This was an MCQ. Commonest site of accessory spleen and extra spleen is the hilum. Greater sac also it is found, but the commonest site of accessory spleen is hilum. Yes. Commonest site of accessory spleen is hilum. Something else? 5 branches of splenic artery. 5 branches of splenic artery supply the individual segments of spleen. Supply the individual segments of spleen. Why is this important? What is the meaning of this point? If you can just tell me. Splenic artery, the splenic artery divides into 5 branches and they supply the individual segments of the spleen. Why is this so important? What am I wanting you to know from this? Answer this. What am I wanting you to know from this statement? 5 branches of splenic artery supply the individual segments of the spleen. That's good. That's good. That's really good. The splenic artery is an end artery. This is what I want you to understand. The splenic artery is an end artery. Splenic artery is an end artery. Okay, see if you can understand this. So 5 branches of splenic artery supply the individual segments of the spleen. Splenic artery is an end artery. Inches, a dimension is in inches. No anastomosis between the branches. Okay, so that's about the spleen. Then you have to know the ligaments of the spleen. Ligaments of the spleen. Just have a look at this. What do you see? Splenic artery has a tortuous course. Yes. It's a branch of celiac trunk. Yes. Supplies the greater curvature of the stomach. By what? What is that artery which supplies the greater curvature of the stomach? The left gastroepiploic artery. Branches anastomosis freely within the spleen. That's wrong. Splenic artery is an end artery. Very good. Okay, that's good. So, fine, clear to all of you? Is this clear to all of you? So which branch of splenic artery supplies the greater curvature of the stomach? Which branch of splenic artery is it? The left gastroepiploic artery. Left gastroepiploic. Okay. Now you have to know the ligaments of the spleen. Ligaments. You know this, ligaments. Ligaments of the spleen. One is the gastrosplenic ligament. Gastrosplenic, you know. The second one, you know, linorenal. Gastrosplenic, linorenal. Gastrosplenic ligament contains what? The short gastric vessels and the left gastroepiploic vessels. The linorenal ligament contains the splenic vessels and the tail of the pancreas. Now the third ligament is very important. The third ligament extends from the diaphragm to the splenic flexure of the colon. Look, this was the splenic flexure of the colon. You remember splenic flexure of the colon? And that's the diaphragm here. This ligament extends from the diaphragm to the splenic flexure of the colon. Now this has got nothing to do with the spleen, but it is just going to support the spleen. It just supports the spleen. Now this ligament extends from the diaphragm to the splenic flexure of the colon. It is just going to support the spleen. A support is known as what? Sustanticulum. And the spleen is known as what? Linus. Sustanticulum linus. Linus is the other name for the spleen. So sustanticulum linus is phrenicocholic ligament. Just listen to this. It is also known as the sustanticulum linus. Not Ritz. It's the suspensory. It is the sustanticulum linus or the phrenicocholic ligament. Okay. Ligament of Treats extends from the crust of the diaphragm to the DJ flexure. From the crust to the DJ flexure. So this is the phrenicocholic ligament. And this phrenicocholic ligament, why is this important? Why am I telling you this? This phrenicocholic ligament is just going to support the spleen. It supports the spleen. And because of this ligament, you know what? The spleen never grows downwards. The spleen cannot grow downwards like this. Why? Because this ligament is going to prevent the downward displacement of the spleen. You following? This ligament, phrenicocholic ligament, is going to prevent the downward displacement of the spleen. So you've seen how does the spleen enlarge? The spleen always enlarge towards the right iliac fossa. That's the reason for that. Spleen enlarges towards the right iliac fossa. So third is phrenicocholic ligament. Phrenicocholic ligament. It is also known as sustanticulum linus. Sustanticulum linus. L-I-E-N-I-S. Sustanticulum linus extends from extends from diaphragm to splenic flexure of colon. Extends from the diaphragm to the splenic flexure of the colon. Prevents the downward displacement of spleen. Downward displacement of the spleen. Clear to all of you? So that's about the linorenal ligament. Linorenal ligament. Just 5 more minutes. I'll just tell you one important organ. Okay, just the important thing I'm telling you. What is asked here? Here, look at this. Just 5 more minutes, then you take a break. I finish this foregut, then we start with the midgut, and the last is the hindgut. Okay, so I'll finish till this much part, till the abdomen. I'll finish for today. So what will be left is pelvis, the lower limb, the histology, that I'll tell you, and the general anatomy. That I don't know when it will be scheduled. Okay, it will be told to you. Now I'll start. What is this now? That's the falciform ligament. Falciform ligament. And this falciform ligament is going to divide the liver into a right lobe and the left lobe. A right lobe and the left lobe. That's the falciform ligament. Okay. Now, what is this surface of the liver? Just have a look at this. What is this surface of the liver? I'm starting with the liver. Just some important things on the liver I'll tell you. The falciform ligament divides the liver into a right lobe and a left lobe. Okay, so what is this surface of the liver? Anterior. So one would be behind, one surface would be behind. This is the posterior surface. If one is anterior, one has to be posterior surface. What is this surface for the liver? Superior. So one has to be inferior surface. Inferior surface. And this is the right lateral. Right lateral. Okay. Now see you. Tomorrow night, she'll tell me now. Once let her see the schedule, and then that madam who manages the schedule will be telling me. Okay, then you'll be informed. Okay, look here. What are the parts of the liver? The liver has got a right lobe and a left lobe. What is this surface? Anterior. So one has to be posterior. This is the superior surface. One has to be inferior surface. And that's the right lateral surface. Okay, so these are the parts of the liver. These are the various surfaces of the liver. Surfaces of the liver. These are the various surfaces of the liver. Okay, now look here. Just try to concentrate on this surface. Oh, look, this is so nice. Just understand this. What is this lobe of the liver? What is this lobe? This is the posterior surface, and this one is the inferior surface. Okay, posterior and inferior surface. And you remember what is this? If you can just tell me what is this that I'm showing you, and what is this that I'm showing you, and what is this that I've marked here for you. Look, what is this coming from front, what is this from behind, and what is this that I've marked? You know this now. You know this. You know this. Yes. Kidney I'll be telling you later. So this is the superior layer of coronary ligament. You remember that? This is the inferior layer of the coronary ligament. And what's this then? That's the right triangular ligament. Same on that side, you'll have a left triangular ligament. And what is this big area here? That's the bare area of liver, bare area. And now you're clear what someone was asking me, why is it known as superior and inferior, and why not anterior and posterior? Now clear, one is at a higher level here and one is at a lower level. So that is why it is known as the superior and inferior layer of coronary ligament. Okay. What is this lobe of the liver? This is the caudate lobe of the liver. Caudate. And what is this lobe of the liver? This is the quadrate lobe of liver. Quadrate. So now you tell me, this caudate lobe of liver, where have we come across? Give me a reference. Caudate lobe of the liver. Where have we come across? Remembering caudate lobe, caudate lobe, caudate lobe. Where was caudate lobe? Caudate lobe of the liver. Yes, it forms the superior boundary of epiploid foramen. Superior boundary of epiploid foramen is formed by caudate lobe of the liver, and this is the caudate lobe of the liver. Okay. Now, what is this lobe of the liver? This is present on the inferior surface, and this is the quadrate lobe. Quadrate lobe. Now, these are some MCQs which are asked. To the right of the caudate lobe is what? IVC. This is IVC. To the left of the caudate lobe is the fissure form. What is this ligament? This is the ligamentum venosum. Ligamentum venosum. Okay. And to the right of the quadrate lobe is what? Gallbladder. And to the left of the quadrate lobe is the fissure form. What is this fissure form? What is this ligament? Ligamentum teres. Now you know ligamentum venosum, you know ligamentum teres. This is what all these things I've told you. And between the caudate and the quadrate lobe, what is this that we get? The porta hepatis. Porta hepatis. Between the caudate and the quadrate lobe, we get the porta hepatis. I'm just telling you the important MCQs which are asked. Clear? Clear to all of you? So what is this lobe which is present on the posterior surface? Caudate lobe. On the inferior surface, quadrate lobe, and between them is the porta hepatis. To the right of the caudate lobe, IVC. To the left of the caudate lobe is the fissure for ligamentum venosum. To the right of the quadrate lobe is the gallbladder, and to the left is ligamentum teres. Clear to all of you? And if you can tell me what is this deep impression for? Look at this. This is the deep impression. I've given you a reference somewhere. Here, what is this deep impression for? There's someone who's fitted inside the liver here. This is the right lobe. This is the right lobe of the liver. There's an organ which is fitted inside, which is related deep here like this. What is that? The right kidney. And the peritoneum which covers the liver, when it comes on the inferior surface, it gets reflected over the kidney. And this pouch is known as the hepatorenal pouch of Morrison's pouch. And when we lie down, and if there's any fluid in the peritoneal cavity, the fluid is going to gravitate into this pouch. What is that? The hepatorenal pouch of Morrison's, the most dependent part of the body in supine position. Understanding this? Yes, right kidney it is. So some things will write here. Okay, I'll just give you here only. You can start with this. Caudate lobe. Just relations you need to know. Caudate lobe. Present on, starting with the liver, topical liver, caudate lobe, present on the posterior surface, to the right of the caudate lobe is IVC, to the left is fissure form, ligamentum venosum. Fissure for ligamentum venosum. Next, quadrate lobe. To the left is the gallbladder. To the right, the fissure form, ligamentum teres. Hepatorenal pouch of Morrison's, most dependent part of the body in supine position. Most dependent part of the body in supine position. To the right, to the right is the gallbladder, to the left. Sorry. To the right is the gallbladder and to the left is, yes, fissure for ligamentum teres. Okay, to the right is gallbladder and to the left is fissure for ligamentum teres. Hepatorenal pouch of Morrison is the most dependent part of the body in supine position. Okay, clear to all of you? Now understand this one last thing here. Understand this Connor's classification. Connor's classification, this much I'll tell you, and then we'll stop. Okay, Connor's classification, this much I'll tell you. Okay, we'll start with Connor's classification. If you know this, you tell me. If you know this, you tell me. Connor's classification. Now, what is the Connor's classification based on? Connor's classification is based on hepatic vein and portal vein. It is based on hepatic vein and portal vein. These two veins. Connor's classification is based on hepatic vein and portal vein. This is surgically important for surgical resection, for surgical removing of a lobe of liver. So just understand this before you write. Okay. The part between the caudate and the caudate lobe is porta hepatis. Okay, I'll start. So Connor's classification is based on the hepatic veins and portal vein. Just have a look at this slide. So hepatic veins are 3. Do not write anything, just concentrate. Hepatic veins are 3. This is the middle hepatic vein. The middle hepatic vein divides the liver into a right lobe and a left lobe. The middle hepatic vein divides the liver into a right lobe and a left lobe. The right hepatic vein, this is the right hepatic vein, and this is the left hepatic vein. Okay, now just understand it like this. The liver is here and the right lobe goes on posterior side. The right lobe of the liver goes back side and the left lobe goes towards the left side. The middle hepatic vein divides the liver into a right lobe and the left lobe. The right lobe goes posterior and the left lobe goes towards the left. Now, the right hepatic vein divides the right lobe into a anterior and posterior part. Anterior and posterior part. This is anterior and posterior part. So the right hepatic vein divides the liver into an anterior and a posterior part, and the left hepatic vein divides the left lobe into a medial and a lateral part. Medial and a lateral part. Look at this once. Look, this is the middle hepatic vein. Divides the liver into a right lobe and a left lobe. Right lobe and left lobe. That's the middle hepatic vein. Okay, like this I'll make. The left hepatic vein, this is the middle hepatic vein, divides the liver into right lobe and left lobe. The left hepatic vein, this is the left hepatic vein, divides the left lobe into a medial and lateral parts, medial and lateral part, and the right hepatic vein divides it into an anterior and a posterior part. This is going back side. I can't make like that for you. So that's the middle hepatic vein, that's the left hepatic vein, and this is the right hepatic vein. You understanding this? This is the right hepatic vein. So just understand it like this. The right lobe goes back side. So the right hepatic vein divides the right lobe into an anterior and a posterior part. The left hepatic vein divides the left lobe into a medial and a lateral parts. Fine. Now the portal vein divides the liver into an upper and lower segments. The portal vein would divide the liver into upper and lower segments. Is this clear? Following this, Connor's classification. We'll start with this Connor's classification based on hepatic vein and portal vein. Hepatic vein and portal vein. The middle hepatic vein divides it into the middle hepatic vein divides the liver into. Okay, just we first finish this. You can see this or no? Tomorrow there's no class. Connor's classification based on hepatic veins and portal vein. Based on the hepatic vein and portal vein. Okay. Now, the middle hepatic vein divides the liver into right and left lobe. Divides the liver into right and left lobe. The right hepatic vein divides the right lobe into anterior and posterior part. The right hepatic vein divides the right lobe into anterior and posterior part. The left hepatic vein divides the left lobe into medial and lateral parts. The left hepatic vein divides the left lobe into a medial and lateral part. The portal vein divides the liver into upper and lower segments. The portal vein divides the liver into upper and lower segments. Okay, now understand this Connor's classification. Okay, look at this now. This segment 1 behind, the segment 1, he has classified it into different segments. Segment 1, don't write this, I have got the slide for this. Segment 1 is the caudate lobe. 2 and 3 is going to be what? Left lateral. 2 and 3 is left lateral. 4A and 4B is going to be left medial. 5 and 8 is going to be right anterior, and 6 and 7 is going to be right posterior. That's how you remember this. Okay, just one moment. That's the slide. You can take this. Segment 1 is behind. That's the caudate lobe. Then segment 2 and 3 is left lateral. 2 and 3 is left lateral. 4A, 4B is left medial. So left lobe is medial and lateral. 5 and 8 is right anterior, and 6 and 7 is right posterior. This is what you have to know. Last point is the portal vein divides it into an upper and lower segment. The last point is the portal vein divides it into an upper and lower segment. This is not with respect to the falciform ligament and ligamentum. The last point is the portal vein divides it into an upper and lower segment. Okay, that was the last point. I'm giving you the break. Okay, so segment 1 is the caudate lobe. 2 and 3 is left lateral. 4A, 4B is left medial. 5 and 8 is right anterior, and 6 and 7 goes back, so that's the right posterior. That's how it is. So just remember this Connor's classification. Yes, just remember this Connor's classification. It's going like this. Yes, it's going like this. So 1 is backside, 2 and 3 is on the left side, left lateral. 4A, 4B is left medial. That's why I told you the left lobe is divided into a medial and lateral part, and the right lobe is divided into an anterior and posterior part. Okay, so 5 and 8 is right anterior, and then 6 and 7 goes back. That's right posterior. That's how you remember. Okay, that's how it is. Fine, you take a break, then we'll start at 15 minutes. We'll start. Now I start with the midgut and hindgut after this. Okay, that's a slide. You can draw this slide if you want. I'm showing you the diagram. Just wait, I'll show you the slide. Falciform ligament is anterior and inferior. Anterior and inferior is falciform ligament. Yes, anterior and inferior. And ligamentum teres is in the falciform ligament. Falciform ligament is on the anterior and inferior surface, and ligament teres lies in the falciform ligament that goes along the inferior aspect. Class till 8:30. Okay. Fine. Okay, we'll stop. Perineum is a totally different topic. Whatever is related today, I'll teach. Because pelvis I can't teach before I finish the lower limb. Once lower limb is clear, you understand the pelvis well. Okay, clear. You take a break. 6 o'clock. 6 o'clock. You take a break till 6. This midgut I'm starting. Midgut. Now what happens is, look, the liver is growing very fast on the right side. Liver is growing very fast on the right side, and because the liver grows very fast on the right side, okay, the liver grows very fast on the right side. Now what happens? There's no place for the midgut inside the abdomen. There's no place for the midgut inside the abdomen. What does the midgut do now? The midgut forms a loop like this, and this loop comes outside the umbilicus. The midgut forms a loop, and this loop comes outside the umbilicus. Okay. Now this is a hernia. This is a hernia, but this hernia is going to reduce back. This is therefore known as a physiological hernia. Physiological hernia. This is therefore known as physiological hernia. Okay. So the liver is growing very fast on the right side. There's no place for the midgut inside the abdomen. The midgut therefore forms a loop, and this loop comes outside the abdomen. Okay, just understand this. I'll make a full screen for you and understand. Okay, so the midgut forms a loop here. I'll start. And this loop comes outside the abdomen. Now this is a hernia, but this hernia is known as a physiological hernia because this is going to reduce back. It will reduce back. It will come back into the abdomen. Okay. Now, understand this now. As this midgut loop comes outside the abdominal cavity, it also carries the artery of the midgut with it. As the midgut loop comes outside the umbilicus, it also carries the artery of the midgut with it. Which is the artery of the midgut? The superior mesenteric artery. Okay, so the superior mesenteric artery enters into this loop, and this superior mesenteric artery divides this midgut loop into two segments. One is above the artery and the second one is below the artery. Just listen to this, then I show you the slide, then I again explain you. Okay. So the midgut loop comes outside the umbilicus. The artery of the midgut, the superior mesenteric artery, also comes out, divides the midgut loop into a pre-arterial segment. This above the artery is the pre-arterial segment, and the segment below is known as the post-arterial segment. Post-arterial. Okay. Now this post-arterial segment gives a small bud here. What is this for? The cecal bud. That's a small bud for the cecum. Cecal bud. Now this midgut loop will undergo rotations. and understand this rotation of the gut. Now this rotation, if you look in your own body, you'll feel that the rotations are clockwise. But remember, we always study the opposite body. We always look into the opposite body. So rotation will always be anti-clockwise. Remember, it will always be anti-clockwise rotation. Now, everywhere, even in the MCQs also, you have to follow anti-clockwise rotations. Anti-clockwise. Okay, let's start. Yo, have a look. So that's the midgut loop. What is this segment? Pre-arterial. What is this? Post-arterial. Now the first rotation is 90 degrees. 90 degrees. This will be anti-clockwise. The first rotation is 90 degrees. When you're looking from front, it will be anti-clockwise like this. Now the pre-arterial segment goes to this. Which is this side for me? The right side. And the post-arterial segment goes to the left side. Okay, now this pre-arterial segment is going to form what? What are these? The small intestines. These are going to form the coils of small intestines, the pre-arterial segment. And as these coils of small intestines are coming back, they are returning back to the abdominal cavity. They pull, and second rotation occurs. The second rotation occurs by how much? 90 degrees. The post-arterial segment now lies superiorly. The cecum is right in the midline. Following this, look here once again. This is how the midgut loop was. This was normal. The first rotation is 90 degrees like this. The pre is on the right, the post is on the left. The pre-arterial segment forms what? What is on the small intestines? And as the small intestines are returning back to the abdominal cavity, second rotation occurs. So now second rotation occurs by 90 degrees. The post-arterial segment lies superiorly. Cecum lies right in the midline. And now this post-arterial segment is coming back to the abdominal cavity. It undergoes a third rotation. So third rotation is by how much? 90 degrees. The cecum lies on which side? Right side. And who's here? Lever. The cecum comes to lie just below the lever, and this is what we call as the subhepatic cecum. So to begin with, when the cecum comes back into the abdominal cavity, it lies below the liver, and this is what we call as the subhepatic cecum. Later it migrates down into its right iliac fossa. So that's rotation of gut. You tell me how many rotations have occurred? 3. How many degrees each? 90 degrees. A total of 270 degrees of rotation a midgut loop undergoes. 270 degrees of rotation a midgut loop undergoes. Okay, so that's about rotation of the gut, a very important MCQ topic. Rotation of the gut. Have a look at this slide, it will be clear to you. Okay, I'll start here. Look now, what is this segment? Pre-arterial. What is this segment? Post-arterial. This is the umbilical opening, and this is the loop of the midgut which has come outside the umbilicus. Okay, that's the loop of midgut which has come outside the umbilicus. What is this artery here? That's the superior mesenteric artery. And this superior mesenteric artery divides the midgut loop into a pre-arterial, and this is a post-arterial segment. Okay, pre-arterial and post-arterial segment. Now understand the rotation of the gut. Okay, so look at me simultaneously. The first, and what is this bud for? Cecum. This is known as the cecal bud. The first rotation is 90 degrees. The pre-arterial segment lies on which side? Right side. The post is on the left side. Okay, pre is on the right, post is on the left. Now this pre-arterial segment is going to form what? Small intestines. Look at this. This pre-arterial segment forms the small intestines, and as the small intestines are returning back, second rotation occurs. Look at this now. Second rotation occurs by how much? 90 degrees. The post-arterial segment is lying where? Superiorly. But the cecum lying? Cecum is right in the midline. This is the three-dimensional view, cannot be drawn on the paper, so it is looking like this. Okay, and finally the post-arterial segment is going back. The last rotation occurs. Where's the cecum now? On the right side. Who's here? The liver. and this cecum is known as the subhepatic cecum. Later the cecum migrates to the right iliac fossa. Understood? So that's rotation of gut. We'll start with this. Understood, no? That's rotation of gut. Okay, so a total of 270 degrees of rotation a midgut loop undergoes. So starting with rotation of the gut, this is nice. Understand this. Starting with the midgut, starting with rotation of gut. Rotation of gut. Okay. Yes. Second rotation is only for pre-arterial segment because the small intestines go for the post-arterial segment. Sorry, because the small intestines go in. No, small intestines are returning back. So second rotation is only of the post-arterial segment. Understood? You'll understand. Just write it down once again. I'll explain. Okay, starting with rotation of gut. The pre-arterial segment. I'm writing this in shorter. The pre-arterial segment. I'll tell that once again. I'll repeat that. Just write this down. The pre-arterial segment lies superiorly and the post-arterial segment, I'm writing this in short, the post-arterial segment lies inferiorly. The pre-arterial segment lies superiorly and the post-arterial segment lies inferiorly. Okay, this is the normal position. Now Roman number 1, first rotation 90 degrees. First rotation 90 degrees. Now the pre-arterial segment, lies on right side. The pre-arterial segment lies on the right side. Second, it forms the small intestines. It forms the small intestines. As it returns back to the abdominal cavity, second rotation occurs. As it returns back to the abdominal cavity, second rotation occurs. Next, second rotation 90 degrees. Second rotation 90 degrees. The post-arterial segment lies superiorly. Cecum lies in the midline. As it returns back to the abdominal cavity, third rotation occurs. As it returns back to the abdominal cavity, third rotation occurs. Next we write third rotation 90 degrees. Cecum lies on the right side. Subhepatic cecum. Cecum lies on the right side, and this is what we call as the subhepatic cecum. Okay, so total of 270 degrees rotations have taken place. 270 degrees of rotation. This one MCQ. Herniation of midgut loop occurs at 6 weeks. Herniation of midgut loop occurs at 6 weeks and reduces at 10th week. Herniation of midgut loop occurs at 6 weeks and reduces at 10th week. So this is how the thing is. Okay, clear to all of you? So that's about rotation of gut. Is this clear to all of you? Once again, I'll repeat this. You can see the slide once again. I'm sorry. See the slide, so it will be clear for you. And then I'll explain. This is very important. This is very important. Rotation of gut. This is a normal rotation which I've told you. This is a normal rotation. Then there is something known as abnormal rotation also. So herniation occurs at which week? 6 weeks, and herniation gets back at 10th week. Clear to all of you? Yes, understanding this rotation of gut, and that's the slide for rotation of gut. Okay. This loop, this midgut loop is herniating outside the embryo into the amniotic cavity. What is the embryo surrounded by? Amniotic cavity, no? So this midgut loop is getting outside the abdomen into the amniotic cavity. Later the amniotic cavity will rupture, no? Okay, clear to all of you? Into the amniotic cavity. Herniation of midgut loop occurs by 6 weeks and reduces by 10th week. Okay, let's have a look at this. Reduces at 10th week. Herniation of midgut loop occurs by 6 weeks and reduces by 10th week. Okay, I'll start once again. Just have a look at this rotation of gut if you have not understood. Okay, listen. That's the midgut loop. The liver is growing very fast on the right side, and because the liver is growing very fast, there's no space for the midgut. What does the midgut do now? It forms a loop like this, and this loop comes outside the umbilicus into the amniotic cavity. Now, this is a hernia, and when does this herniation occurs? 6 weeks. But this hernia is going to come back. When does it come back? 10th week. This is why we call this as a physiological hernia. Now, as the midgut loop comes out, it also carries the artery of the midgut with it. So this segment of the midgut loop is above the artery. What do we call this as? The pre-arterial segment. And this segment is below the artery. What is that? Post-arterial segment. And this post-arterial segment gives a small bud here for the cecum. What do you call this bud as? This bud is known as the cecal bud. Okay, I start now. Rotations, when you look from front, will be anti-clockwise here. The first rotation is 90 degrees. So the pre-arterial segment lies on the right side. The post is on the left side. Now the pre-arterial segment forms what? Small intestines. And as the small intestines are returning back, second rotation occurs. So second rotation occurs by 90 degrees. The post-arterial segment is superiorly. Cecum lies in the midline. Then you put, as this post-arterial segment is coming back, third rotation occurs. So third rotation occurs by 90 degrees. Cecum is on the right side. That's a subhepatic cecum. Is this clear to all of you? Yes? Okay, no? Now this is normal rotation. Understand some abnormal rotations. Okay, just understand. This is slightly difficult to understand. Now look here. This was normal rotation. So now that's the pre-arterial segment, that's the post-arterial segment. Normally this entire loop turns by how much? 90 degrees. This entire loop turns by 90. But in this case, this is an abnormal rotation, malrotation. In this case, only this. Who's this? Pre-arterial segment. Alone turns by 90 degrees. Now, only this. Who's this? Post-arterial segment. Alone turns by 180 degrees. Where's the cecum? Right in the midline. The cecum is right in the midline. And this type of rotation is known as mixed rotation, mixed rotation. Anyway, cecum once comes in the midline. Once cecum comes in the midline. When is that? Normally also. Normally cecum once comes in the midline. That's in second rotation. That's normal. But if it is specifically asked, cecum is found in the midline below the stomach, what is the type of malrotation? Your answer is mixed rotation. Mixed rotation. Clear? Understanding how? Look, the first rotation, only the pre-arterial segment turns by 90. Second rotation, only the post-arterial segment turns by 180. Cecum is right in the midline. Okay, and this is known as the mixed rotation. Fine. Second type of malrotation. The first rotation is normal. That's a normal rotation. After this, no rotation occurs. No rotation. The entire loop comes back. The entire loop comes back into the abdominal cavity. Where's the cecum now? Cecum is on the left side, and the cecum is the beginning of what? Large intestine. That means the entire colon lies on left side, and this is what we call as a non-rotation. Non-rotation. You understanding? Non-rotation. So what is non-rotation? Look here. The first rotation is normal. Further, no rotation occurs. The entire loop comes back to the abdominal cavity. Cecum on the left, the entire colon on the left. That is malrotation. You know, in one of the CPT I had given one MCQ. During surgical exploration, the surgeon accidentally finds that the entire colon is on the left side. What is the type of malrotation? Your answer, non-rotation. Non-rotation. Following this? And last. The first rotation is normal. Now, the second rotation occurs by 180 degrees, but in reverse direction. Reverse 180, reverse. Okay, look here. This is normal. The first rotation is normal. The second rotation occurs by 180 degrees, but in reverse direction. Where's the cecum now? On the right side. In us, normally also cecum is on the right side. But in this case, something different happens. Look, normally in us, who's returning first? Who's returning back to the abdominal cavity first? Small intestines. So the small intestines goes in first, and then the post-arterial segment goes in. The post-arterial segment forms a colon. In us, in our case, the transverse colon lies anterior to the small intestine, because the small intestines go in first and they are attached by the mesentery. And finally the transverse colon comes in front. So in us, the transverse colon is anterior to the small intestines. But in this case, the last case, which is known as reverse rotation, the first rotation is normal. The second rotation occurs by 180 degrees, but in reverse direction. Cecum is on the right side. In this case, the post-arterial segment goes in front, and the transverse colon is attached by the transverse mesocolon, and then the small intestines goes in, and in this case the transverse colon lies posterior to the small intestines. You understanding this? Because the post-arterial segment goes in first, so the transverse colon is attached first, and then the small intestines go in, and this is how the transverse colon comes to lie behind the small intestines. And what is this rotation known as? A reverse rotation. This is what we call as reverse rotation. Okay. Subhepatic hai baba, subsplenic who's telling in that case. Okay, clear to all of you? You'll understand this way. As you write, you'll understand. See, teaching on the satellite is really difficult. Understand, face to face it's very easy for me to teach. And face to face students are right in front. I can look at the students, I can understand how much the students are understanding. Okay, but VSAT on a satellite it's very difficult to teach. But still I'm trying my level best to make you understand. Okay, fine. Now, starting with malrotation. Malrotation. Starting with the first, mixed rotation. Mixed rotation. Starting with the first one, that's mixed rotation. Okay, the pre-arterial segment The artery of the midgut, that's a superior mesenteric artery. Okay, they're divided. The pre-arterial segment alone rotates by 90 degree. Pre-arterial segment alone rotates by 90 degree. Second, the post-arterial segment alone rotates by 180 degrees. Yes, I'm telling you, just wait. The post-arterial segment alone rotates by 180 degrees. Cecum lies in the midline. Cecum lies in the midline. Clear to all of you? That's its mixed rotation. Second, non-rotation. First rotation is normal. The first rotation is normal. The first rotation is normal. Further rotation does not occur. Cecum lies on the right side. Cecum lies on the left side. Left-sided colon. Only thing is that I'm very, very strict in face-to-face lectures. I don't allow students even to talk. Okay, irrespective of whether it is a big auditorium, students sitting down, students sitting in the balcony, anywhere. But I don't allow the students to talk at all. The third is reverse rotation. If anyone has attended the lectures, reverse rotation. Okay, first, the first rotation is normal. The first rotation is normal. Second rotation occurs by 180 degrees in reverse direction. Second rotation occurs by 180 degrees in the reverse direction. Post-arterial segment returns first. Post-arterial segment returns back first. The transverse colon lies anterior to, transverse colon lies posterior to small intestines. Transverse colon lies posterior to the small intestines. I'll be coming to the centers. Wait, just the corona get off from here, because I'm the single faculty. Okay, and I teach at all the centers. And students, I told you, who are sitting like you are now good faculties. Okay, of times whom we have taught. Clear. So the first rotation is normal, the second rotation occurs by 180 degrees in reverse direction. The post-arterial segment returns first and the transverse colon lies behind the small intestines. Is this clear? Normally the pre-arterial segment returns first. No, normally the pre-arterial segment returns first. Normally what happens is the pre-arterial segment goes in first. No, the small intestines goes in first and then they get fixed and then the transverse colon comes inside. So normally what happens in us is the transverse colon is in front of the small intestines. In reverse rotation what happens is the post-arterial segment goes in first and then is fixed by the transverse mesocolon. So transverse colon gets fixed first and then the pre-arterial segment gets in, no, and the small intestines. You understood? Yes? Clear to all of you? Yes, that's it. So that's about the rotation of the gut. It should be clear to all of you. So that's about the rotation of the gut. I'll tell you this also. I'll tell you here only. I'll tell you this here only. Understand this. So direction is anti-clockwise. Just follow anti-clockwise because we are studying in the opposite body. So it will be anti-clockwise only. Just take it as anti-clockwise. So no confusion. Anti-clockwise. Okay. Very good. This should be perfect. Perfect. Okay. Now starting with this. Have a look at this. This is the last part of the gut. Last part. This is the last part of the gut. Okay. Starting with this last part of the gut. One moment. Before this, then I'll tell you the kidneys first. Kidneys. Development of kidneys I'll tell you first. Because now relations of the kidneys you know. I'll just start with the development of the kidneys and the bladder. Relations of the kidneys I've told you. Just have a look at this. Development of kidneys. And then I'll tell you the hind gut. So this will be easy to understand. Okay. I am professor and head anatomy. Clear? I'll start. Have a look. Reverse rotation is clear. Look here. This was the loop. The first rotation is like this, 90 degrees. The second rotation is in the reverse direction like this. It goes in reverse direction. The cecum is on the right side. Okay. Cecum is on the right side. In this case, the post-arterial segment returns first and then the pre-arterial segment. The post-arterial segment goes in front and then the pre-arterial segment returns first. Yes. Okay, I'm starting here. Now look here. You remember the ectoderm, you remember the mesoderm, you remember the endoderm. Right. So this ectoderm, the intraembryonic mesoderm, and the last one is the endoderm. And who lies in the intraembryonic mesoderm? Right in the center of the mesoderm. Who lies? That is the notochord. Notochord. Right in the center of the mesoderm lies the notochord. The first mesoderm on either sides of the notochord is what? The paraxial mesoderm. The next mesoderm is the intermediate plate mesoderm. And the last one is the lateral plate mesoderm. Lateral plate. Okay, so paraxial mesoderm, intermediate plate mesoderm, lateral plate mesoderm. So paraxial mesoderm, you know, forms the somites and all. Dermatome, sclerotome, this all you know. Intermediate plate mesoderm, you remember intermediate plate mesoderm, we had put an arrow and written, forms the genitourinary system. Genitourinary system is derived from intermediate plate mesoderm. Okay, starting with this, development of kidneys. And last was what? Lateral plate mesoderm, you remember, encloses a cavity. What was that cavity known as? Intraembryonic coelom. And this forms all the body cavities. Okay, starting with the intermediate plate mesoderm. Have a look, understand this. The intermediate plate mesoderm lies between the paraxial and the lateral plate mesoderm. This intermediate plate mesoderm forms four things in it. Do not write anything, just listen to this. It forms four structures. One, it forms a long ridge extending from the cervical to the pelvic region, and this is what we call as the nephrogenic ridge. Nephrogenic ridge, a long ridge extending from the cervical to the pelvic region, and this is known as the nephrogenic ridge. On the medial side of the nephrogenic ridge, we get another ridge named gonadal ridge. Gonadal ridge, and two ducts are formed here. What is that? The mesonephric duct and the paramesonephric duct. What are we discussing? What are we discussing? Intermediate plate mesoderm. Okay, intermediate plate mesoderm is a part of intraembryonic mesoderm. This intermediate plate mesoderm forms four things. One is a long ridge here. What's that? The nephrogenic ridge extending from the cervical to the pelvic region. Next, a ridge on the medial side named gonadal ridge, and two ducts are formed here, the mesonephric and the paramesonephric ducts. You following this? Okay, starting with this intermediate plate mesoderm. Just write this down. This is development of kidneys. Development of kidneys. Intermediate plate mesoderm forms one. Nephrogenic ridge. Second, gonadal ridge. These are the four things. Third, mesonephric duct. And the paramesonephric duct. Paramesonephric ducts. So all this is what in origin endodermal. All this is what in origin mesodermal in origin. Mesodermal. All this will be derived from mesoderm. What's that? A long ridge extending from the cervical to the pelvic region, the nephrogenic ridge. Medial to the nephrogenic ridge is the gonadal ridge. And what is formed in the gonadal ridge? The testis and the ovary. That means the testis and the ovary is derived from what? Mesoderm. Mesoderm. And two ducts, the mesonephric and the paramesonephric duct. Starting here, have a look here, understand this now. Okay, starting here, look. This is a long ridge here. What is this ridge known as? Nephrogenic ridge. That's the nephrogenic ridge. Okay. Now this nephrogenic ridge extends from the cervical region to the pelvic region. Now this nephrogenic ridge is divided into three parts. In the cervical region, what do we call this as? Pronephros. This is pronephros. In the thoracic and the lumbar region, what do we call this as? Mesonephros. And in the pelvic region, we call this as the metanephros. Metanephros. So pronephros, mesonephros, metanephros. These are the parts of nephrogenic ridge. Just listen to this. Now there is a duct here. There is a duct which is draining. This is the duct. Look, this is the duct which is draining the pronephros, mesonephros, metanephros. And what is this duct known as? The mesonephric duct. This is the mesonephric duct. And this mesonephric duct opens into the future bladder. Opens into the future bladder. This I have to tell you. And look. This bladder is communicating with the umbilicus through urachus. That's urachus. Okay, so that's urachus. Okay, I start. Look at this now. Here, what is this long ridge here? The nephrogenic ridge. Three parts. In the cervical region, pronephros. In the thoracic and the lumbar region, mesonephros. In the pelvic region, metanephros. One duct drains this. What is this duct known as? Mesonephric duct. Drains the pronephros, mesonephros, metanephros. That's the mesonephric duct. Now, what happens to the pronephros and us? They disappear off. What happens to the mesonephros? This mesonephros forms small tubules. What are these tubules known as? Mesonephric tubules. They also degenerate off, but they form some vestigial remnants. We'll see this later. So the pronephros disappears off. The mesonephros forms small tubules, the mesonephric tubules. What is functional in us? The metanephros. Okay, what is functional in us? The metanephros. And this metanephros is going to form what? The secretory part of the kidney. Secretory part meaning the urine forming part. The urine forming part of the kidney is derived from metanephros. Now what does this metanephros include? the Bowman's capsule, the PCT, the loop of Henle, the DCT. Okay, this is derived from metanephros. The Bowman's capsule, the PCT, the loop of Henle, and the DCT. If anyone has got old notes, just make this correction. Okay, so this is derived from metanephros. The Bowman's capsule, the PCT, the loop of Henle, and the DCT. First we used to include the collecting ducts also, but now it is not included. Okay, this is derived from metanephros. Now, what is this duct here? Don't write anything. I'll be giving you all these things. Don't write anything. What is this now? What is this? This is the mesonephric duct. And this mesonephric duct is opening into what? This is the bladder. And this mesonephric duct gives a small bud here. What is this bud known as? The ureteric bud. The ureteric bud. And this ureteric bud will be entering into, it will enter into the metanephros. And the moment it enters the metanephros, it now stimulates the metanephros to form the kidney. It would stimulate the metanephros to form the secretory part of the kidney. What is this? Ureteric bud. And this ureteric bud divides and redivides, and what is this going to form? Collecting part of the kidney. So collecting part of the kidney is derived from ureteric bud. Okay, so what is it going to form? The collecting ducts, the minor calyx, the major calyx, the pelvis, and the ureters. All this is derived from ureteric bud, and the ureteric bud itself is given by mesonephric duct. Simple, it is simple. You just have to understand this. So the secretory part of the kidney is derived from metanephros. The collecting part of the kidney is derived from ureteric bud. Okay, this ureteric bud will be forming the collecting system, the entire collecting system, the ureters and all. Okay, don't see this now. This is changed. It forms the collecting ducts, the minor calyx, the major calyx, the pelvis, and the ureters. So that's the collecting part, and that's the secretory part. Okay, normally what happens is this collecting part and the secretory part, they are separate. No, they are different sources, and this collecting and the secretory part have to communicate with each other. They have to communicate. MCQ is failure of communication of the collecting and the secretory part results in you get small cyst in the kidney, and this is what we call as a congenital polycystic kidney. Sometimes the ureteric bud itself is not formed. Failure of ureteric bud to form results in, now look, this ureteric bud will be migrating, will be going into the metanephros, and it would stimulate the metanephros to form the kidney. If this ureteric bud itself is not there, the kidneys are not formed at all because they are not stimulated, and this is known as renal agenesis. So failure of ureteric bud to form results in renal agenesis. And now you tell me, where are the kidneys formed? The kidneys are formed in the pelvis first to begin with. Why? Because the metanephros is in the pelvis, no, and this metanephros will form the kidney. So kidneys are first in the pelvis, and the hilum is facing forwards like this. Hilum is in front. Now this kidneys would start to ascend up. That's the diaphragm here. That's the diaphragm, and that's, now they can't go above this, and now the hilum faces medially. That's the final position of kidney. Following this, so kidneys, when they are formed, they are first formed in the pelvic region because the metanephros is in the pelvis and the kidneys hilum is in front. Now the kidneys will ascend up and the hilum faces medially. That's it. But suppose, now, why do the kidneys ascend up? Why do they go up? There are two theories for this. One is the differential growth of the body wall. The body wall grows very fast, so the kidneys are automatically pulled up and the hilum faces medially. That's one. Second theory, the kidneys require a high pressure for filtration of blood. So when they are in the pelvis, the pressure which they get from the heart is too less. They need a higher pressure, and that's how they start to ascend up. Okay, these are the two theories. These are just theories, just remember this. Now, so that's how the kidneys go below the diaphragm, and now the hilum faces medially. But suppose if the kidneys get a chance to enter the thorax, they would go into the thorax and lie on either sides of the heart. The pressure for filtration of blood is maximum, and this is what is known as Bochtelic's hernia. And what is Bogdan's hernia? It's a posterior and lateral defect in the diaphragm. This I told you. You remember, a posterior and lateral defect in the development of diaphragm due to non-fusion of pleuroperitoneal membranes. Due to non-fusion of pleuroperitoneal membranes, and that is Bogdan's hernia. And who herniates up are the kidneys. Remember that. There are other structures which also herniate up, but the most important structure is the kidney. Okay, Bogdan's hernia, non-fusion of pleuroperitoneal membranes. That's what you have to what you're supposed to know about the kidneys, right? We'll just finish this. Clear to all of you, no? Okay, start now. Okay, starting with development of kidneys. Development of kidney. Posterolateral defect in the development of diaphragm. Okay, starting with this development of kidney. Okay, here we are. Start. Just the MCQs I'm telling you. Kidneys. Secretory part of the kidney. Understood now, all of you? Yes. Secretory part of the kidney is derived from metanephros. This is the important thing. This is secretory part of the kidney is derived from metanephros. If metanephros is not in the option, this is development of kidneys. If metanephros is not in the option, it is metanephric blastema. Metanephric blastema. Secretory part of the kidney is derived from metanephros or metanephric blastema. Forms Bowman's capsule. Forms the Bowman's capsule. PCT. Loop of Henry. Okay, cancel that collecting ducts if you have written there. Recent edition of Langman's doesn't mention like that, so I'm changing that. Okay, collecting part of the kidney is derived from collecting part of the kidney is derived from collecting part of the kidney is derived from ureteric bud. Ureteric bud. The other name for the ureteric bud, this was an MCQ, a CET MCQ. It is known as the metanephric diverticulum. Metanephric diverticulum. Okay, so collecting part of the kidney is derived from ureteric bud. Ureteric bud is also known as the metanephric diverticulum. Forms collecting ducts, minor calyx, major calyx, pelvis, ureter. Okay, ureteric bud. Ureteric bud itself is derived from mesonephric duct. If ureteric bud is not in the option, mesonephric duct is in the option. Ureteric bud is also known as metanephric diverticulum. This was a CT MCQ. Metanephric diverticulum forms the collecting duct, minor calyx, major calyx, pelvis and ureter. Some MCQs. Failure of communication of collecting and secretory part. Failure of communication of collecting and secretory part results in congenital polycystic kidney. Results in congenital polycystic kidney. Failure of ureteric bud to form. Failure of ureteric bud to form results in renal agenesis. And the last, okay, words are not clear. Okay, clear to all of you? Look, failure of communication of the collecting and the secretory part results in what? A congenital polycystic kidney. Failure of ureteric bud to form results in renal agenesis. You're clear to all of you? Now look, what did I tell you? Where are the kidneys formed? They're formed in the pelvis. And where is the hilum facing? Forwards. And now the kidneys will start to ascend up. And the hilum now faces medially. That's the final position of kidney. But suppose if the lower poles of the kidneys are connected to each other, what is that known as? A horseshoe-shaped kidney. And when such a horseshoe-shaped kidney starts to climb up, someone is going to stop it. Who's this? Who's going to stop this? This is the inferior mesenteric artery. This is inferior mesenteric artery. Who prevents this? It degenerates off. The metanephros will degenerate off. Look at this slide and look at this slide and tell me now. Look, this is a horseshoe-shaped kidney, and a horseshoe-shaped kidney is going up. Who's going to prevent it from going up? What is this artery? This is the inferior mesenteric artery. So MCQ is a horseshoe-shaped kidney remains below. Level is L3. It will remain below L3 because level of inferior mesenteric artery is what? L3. So horseshoe-shaped kidney will remain below L3. Horseshoe-shaped kidney remains below L3. Horseshoe-shaped kidney remains below L3. That's below inferior mesenteric artery. Is this clear to all of you? Why do the kidneys ascend up? Look, there are two theories for this. One is the differential growth of the body wall. The body wall grows very fast, so automatically the kidneys are pulled up. Second theory, the kidneys require a high pressure for filtration of blood. So when they are in the pelvis, the pressure which they get is too less, and that's how the kidneys will start to ascend up, because they require a high pressure for filtration of blood. Okay, understand this now. Look at this. Histology, I'll tell you later. Look at this slide. Look at this slide now. Okay, here we are. Now tell me. Okay, tell me now. The bladder. The bladder is derived from what? You remember the hindgut. The last part of the gut is known as hindgut, and this hindgut forms the rectum and the anal canal behind and the bladder in front. That means bladder is derived from the hindgut. And what is the gut? What is the lining of the gut? Endoderm. Endoderm. The entire GIT is what in origin? Endodermal in origin. That means the bladder would be derived from what? Endoderm. Endodermal in origin. Bladder would be, because it is derived from the hindgut. Okay, so bladder is endodermal in origin. And now look, what are these two ducts here? These are the two mesonephric ducts. Mesonephric ducts are what in origin? Mesodermal in origin, right? Mesonephric ducts are mesodermal in origin, and this mesonephric ducts will give this bud here. What is that for? Ureter, ureteric bud. Now at this point of time, If we look inside the bladder, how many openings are we going to see inside the bladder? Two openings of two mesonephric duct. Okay, so you'll see two openings of two mesonephric duct inside the bladder. After some times, what happens is this much part of the mesonephric duct, is absorbed into the bladder. It's absorbed into the bladder. So now how many openings do you get inside the bladder? 4. 2 of the mesonephric duct and 2 of the ureteric bud. This much part of mesonephric duct is absorbed, and now we get 4 openings, 2 of the mesonephric duct, 2 of the ureteric bud. And this much part of the mesonephric duct which is absorbed in the bladder forms what? What is this for the bladder? Trigone of the bladder, trigone. And that is how we say the entire bladder is endodermal in origin except the trigone which is mesodermal in origin. You're following this? Because the trigone is derived from the absorbed mesonephric duct. This mesonephric duct is mesodermal in origin, so the trigone is therefore mesodermal in origin. Okay, is this clear to all of you? How the mesonephric duct is absorbed? Okay, just add the sentence now. Just add the sentence. The entire bladder is endodermal in origin. Just add the sentence. Entire bladder is endodermal in origin. Except. Just add the sentence. Entire bladder. Entire bladder is endodermal in origin. Except trigone which is mesodermal. Mesodermal, absorbed mesonephric duct. Absorbed mesonephric duct. That was horseshoe-shaped kidney remains below L3. Yes, remains below L3. Okay, clear to you? The entire bladder is endodermal in origin except the trigone which is mesodermal in origin. Clear to all of you? Right. Understand this now. Okay, starting with the development of IBC. Starting with the development of IBC. Okay, so this will complete the abdomen then. Other than Bochdalix hernia, if it occurs, Bochdalix hernia, the spleen goes up, the stomach goes up, the transverse colon goes up, the small intestine can also go up into the thorax, but the most important organ for us are the kidneys. Okay, fine. Starting with this now, have a look at this slide. Development of IBC. I'll start. Development of IBC. Look at this. Chalo, you know this. You know this slide. I'll just let it get clear. Okay, here we are. What is this slide? You remember what is this slide? Here, look at this slide and tell me. I'll start. Okay, you know everything of the slider. You know everything. Quickly tell me. Who's this? Who's this? And who's this? Remember? Who's this? Who's this? And who's this? It is known as metanephric diverticulum. We don't know why it is known as, but it is labeled as metanephric diverticulum, and that was a specific MCQ. Because it is a diverticulum which is derived from mesonephric duct which is going towards the metanephros. Okay, it's like that. Answer this. Yes, very good. This is the anterior cardinal vein. That's the posterior cardinal vein. And this is the common cardinal vein. You remember this? Anterior cardinal vein, posterior cardinal vein and common cardinal vein. Okay, you remember this, no? And you remember this also. Look, this was the anterior cardinal. Quick revision. This was the posterior cardinal, and what was this? Common cardinal vein. The common cardinal vein was draining into what? Answer that. The common cardinal vein drains into what? Into the sinus venosus. Yeah, the common cardinal vein drains into the sinus venosus. Fine. Now there was an anastomosis. If you remember this, there was an anastomosis between the two anterior cardinal veins. And you remember what was this veins which were opening into the anterior cardinal veins? What were these veins? Subclavian vein. Very good. Subclavian vein. Okay, this you know. A quick go through it. Tell me, what was this forming? Okay, what was this forming? I'm not going into this topic again. What was this forming? Internal jugular vein. Okay, this was forming the internal jugular. What was this forming? Right brachiocephalic. What was this entire vein forming? This and the anastomosis. What was that? Left brachiocephalic. What was this forming? This SBC. Remembering? So SBC is derived from the right anterior cardinal vein below the anastomosis and the right common cardinal vein. And what was this forming? This much part. Answer this. What was this forming? This one. Only this much part. What is this form? Coronary sinus. Yeah, you remember this? So coronary sinus is derived from the left common cardinal vein and the left horn of sinus venosus. And then what is this form and what is this form? What is this and this form? What is this and this form? This was forming the left superior intercostal vein. That was forming the left superior intercostal vein. Okay, that's fine. So this was forming the left superior intercostal vein. Right, very good, very nice. Chalo, you understood everything. Coming back to the slide. Here we are. Coming back to the slide. Okay. Now someone was very interested in IBC that day, no? Look, I'll start. Here we are. What is this now? This is the posterior cardinal vein. And the two posterior cardinal veins are connected by an anastomosis. They are connected by an anastomosis. Like you remember, the two anterior cardinal veins are connected by an anastomosis, and that anastomosis was forming what? The left brachiocephalic. Similarly, the two posterior cardinal veins are connected by an anastomosis. Okay, so the two posterior cardinal veins are connected by an anastomosis. Now, two new veins are formed here. Look at this. Two new veins are formed here in green. And what are these veins in green known as? Just listen, this is difficult. Just listen. These two veins in green is known as the subcardinal vein. The subcardinal vein above and below are connected to the posterior cardinal vein. The subcardinal vein above and below are connected to the posterior cardinal vein. Okay, now this subcardinal vein, now there are two small kidneys forming here. Look at this. These are the two kidneys which are forming here, and these two kidneys would be draining into the subcardinal vein by what is this small vein known as? This one. This is the mesonephric vein. Have a look once again. What is this in black? This is the posterior cardinal vein. Now two veins come and join. Two veins are formed on either sides here. What are these two veins known as? The subcardinal vein. The subcardinal vein above and below are connected to what? Posterior cardinal vein. They are connected above and below to the posterior cardinal vein. Two kidneys are forming here, and the kidneys would drain into the subcardinal vein through what are these small veins here? The mesonephric vein, and the two subcardinal veins are connected to each other by what is this now? This is known as an intersubcardinal anastomosis. Intersubcardinal anastomosis. Just wait, don't write anything. Now listen. I'm telling you, this is going to form our future IVC. Okay, this vein is going to form our future IVC. So now, if this is going to form the future IVC, tell me what is this going to form? This one. this will form the right renal vein. Right renal vein. So the right renal vein is derived from the right mesonephric vein. Okay, so the right renal vein is derived only from right mesonephric vein. The left renal vein is derived from 1. The left mesonephric vein, 2nd. The left subcardinal vein, and 3rd, the intersubcardinal anastomosis. That's the left renal vein. Now, which renal vein is longer? The left is longer. Why? Because the IVC is formed on right side. IVC is formed on the right side. So the left is longer and the right is short. Okay, this is the development of renal veins. Renal veins. Just draw this slide. You just draw this slide. So starting with development of IVC, before I tell you the IVC, I have to tell you this. Okay, just draw the slide. Labelings, I'll tell you. We'll do the labelings. Just draw the slide. This is development of IVC. Okay, just draw this, finish this. Okay, so we are coming close to the end of the abdomen. Okay, finish this fast. If the labelings are done, you tell me. I'll tell you this once again. So I've labeled this as posterior cardinal vein. I've labeled this as the subcardinal vein. I've labeled this as the mesonephric vein. And I've labeled this as the intersubcardinal anastomosis. Intersubcardinal anastomosis. Done with this? Clear? I'll start now. Fine. Just look here once again. Labeling is clear now? Okay. Now tell me. Look here once again now. What is this going to form? Here, listen here now. What is this going to form? What is this going to form? This is going to form the left renal vein, or right renal vein, sorry. So how is the right renal vein formed? The right renal vein is derived from the right mesonephric vein, And how is the left renal vein formed? The left renal vein is derived from the left mesonephric vein, 2nd. The left subcardinal vein, 3rd. The intersubcardinal anastomosis. Intersubcardinal anastomosis. Clear? Just write this down now. So sorry, one moment. Development of renal veins. Just write down. Development of renal veins. Okay. Now I've just left the last topic for you. This now pelvis and perineum. I just tell you the ureters, okay, ureters, because now you know the entire ureter. Later you are not going to remember that. So, okay, development of renal vein. Have a look, understand this. Development of renal vein. Right renal vein. Right renal vein is derived from right mesonephric vein. So right renal vein is derived from the right mesonephric vein. 2nd, left renal vein. Left renal vein is derived from one left mesonephric vein, left subcardinal vein, third intersubcardinal anastomosis. Intersubcardinal anastomosis. Intersubcardinal anastomosis. Okay, so that's about the right and the left renal vein. Be very clear about this. So the left renal vein is longer because the IVC is formed on the right side. That's how the left renal vein becomes longer. This should be clear. Now understand this slide now. Something more difficult here. Now I'll start. If you're done with this, I'll start. Okay, have a look here now. Tell me now. Yo, listen now. What was this now? This was the posterior cardinal vein. What was this vein here? What was this vein? This was the subcardinal vein. Now two new veins are formed here, and this are known as no, I'm not saying that you will forget what you've learned. I'm not saying that you'll not remember the ureters that time, because you will remember everything. I'm not saying that, but that ureter part which I've told you today, no, if I don't finish ureters today, you'll not be able to recollect the part of ureter which I've told, which I've not given you to write. When you write, it enters in your brain. So when the things are there in your notes, you will be reading it, you'll be able to understand it. But the ureter part we have not written. I've just shown you parts of ureter here and there. So that part you might not be able to recollect. So don't take it in the wrong sense. Okay, fine. I'm very clear about my things. Fine. So look here now. What is this posterior cardinal vein? Now what is this vein? This is the subcardinal vein. Subcardinal vein. Now two new veins are formed here. This is known as the supracardinal vein. Supracardinal vein. And both the supracardinal veins above and below are connected to the posterior cardinal vein. Okay. Yes, both the supracardinal veins above and below are connected to the posterior cardinal veins. Look at that. This is the supracardinal vein which is connected above and below to the posterior cardinal veins. Now this supracardinal is connected to the subcardinal vein. Have a look here. This supracardinal vein is connected to the subcardinal vein by what you call this as. This is known as the supra-subcardinal anastomosis. Here. This is known as the supra-subcardinal anastomosis. Okay, so the supracardinal vein is connected to the subcardinal vein by what is this known as supra-subcardinal anastomosis, and this is going to form the last part of the IVC. The last part of the IVC, and this is known as this part of the IVC is there in the liver and the heart, and this is what we call as the hepatocardiac channel. Hepatocardiac channel. Okay, just draw this slide. Okay, draw this B slide. Hanging, no, because okay, fine. Just draw that, I'll label that. Just draw that, I'll label that. हेलो, जस्ट में जरा हैंग हो गया, देखो उसको वापस ये कर दो. वो मैंने इमेज मैग्नीफाई किया. ठीक. I'll label that. I'll label that. I'll label that. You just draw that. I'll label that. Fine. No, started. I'll label that. I'll start. I'll label that. Chalo, start. This the new ones you label. This is known as the supracardinal vein. Supracardinal vein. The one in red. The one in red is the supracardinal vein. The one in red is supracardinal vein. I'll repeat that. I'll repeat that. The one in red is supracardinal vein. Okay, I'll start. The one in red is the supracardinal vein. Supracardinal vein. Fine. This is known as the supra-subcardinal anastomosis. Supra-subcardinal anastomosis. Supra-subcardinal anastomosis. So this is the supracardinal vein, this is the supra-subcardinal anastomosis, and this is known as the hepatocardiac channel. Hepatocardiac channel. Okay, so this in red is supracardinal vein. This is the supra-subcardinal anastomosis. Supra-subcardinal anastomosis, this one. This is the supra-subcardinal anastomosis, and this one is the hepatocardiac channel. Hepatocardiac channel. Okay, done. Look here once again. I'll just go through it. Now understand the development of IVC. Hepatocardiac channel is the last part of the IVC which is there in the liver and the heart. Okay, just to summarize once again, have a look. I'll start. I'll start. Just listen. What is this in black? This is the posterior cardinal vein. The one in red, supracardinal vein. The one in green, the subcardinal vein. What is this? This is the supra-subcardinal anastomosis. What's this? The intersubcardinal anastomosis. And what's this? This is the hepatocardiac channel. Hepatocardiac channel. Okay. Now, how is the IVC formed? IVC. Look, it is so easy. You just have to go like this, like this, like this, this and this. That's how the IVC is. If you're starting from above downwards, you just have to sit here and you have to slide down, 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 down and down. That's how the IVC is formed. I'll start. IVC is derived from, yellow is hepatocardiac channel, hepatocardiac channel, hepatocardiac, the one in liver and the heart. Okay, I'll start. How is the IVC formed? 1. IVC is derived from 1. The right posterior cardinal vein. Right posterior cardinal vein. So everything is on the right side, so I'm not specifying. The posterior cardinal vein. 2nd, the supracardinal vein. 3rd, the supra-subcardinal anastomosis. 4th is the subcardinal vein, and 5th is the hepatocardiac channel. Hepatocardiac channel. Okay, this is how the IVC is formed. Okay, once again, have a look here. IVC is derived from 1. What's this here? What's this? This is the posterior cardinal vein. This is the supracardinal vein. This is the supra-subcardinal anastomosis. This is the subcardinal vein. And this is the hepatocardiac channel. Hepatocardiac channel. Yes, they are the same. Hepatocardiac channel. Okay. So that's about the development of IVC. We'll just write this down. Development of IVC. Starting with development of IVC. This now keeps on going back to the normal one, original one. Okay, starting with development of IVC. You write it down. I'll start. Development of IVC. 1. Posterior cardinal vein. Development of IVC. 1 is posterior cardinal vein. Everything is on the right side, so this is right. Posterior cardinal vein. posterior cardinal vein. Second, supracardinal vein. Supracardinal vein. Third, subcardinal anastomosis. Subcardinal anastomosis. Fourth, subcardinal vein. And fifth, hepatocardiac channel. Hepatocardiac channel. Hepatocardiac channel. That's the yellow and blue. Hepatocardiac channel. What is that? I'll tell you later. Hepatocardiac channel. Okay, if you can just tell me. Just look at this, huh? What is the blood supply of suprarenal gland? Just one moment, I didn't tell you this. Have a look. What is the blood supply of suprarenal gland? How many arteries supply the suprarenal gland? That's the suprarenal gland. Just have a look. 2 minutes. 2 minutes, just listen here. 2 minutes, let me finish this. That IVC, a part is left, you will understand. Just wait, let me finish this. What are the arteries supplying the suprarenal gland? You remember the first lateral branch of abdominal aorta, which was going up. The first lateral branch of abdominal aorta which was going up, what was that? Inferior phrenic. The inferior phrenic gives the first artery to the suprarenal gland. What is that? Superior suprarenal artery. So superior suprarenal artery is a branch of inferior phrenic. The middle suprarenal artery is a branch of this is a direct branch. You remember, middle suprarenal artery is a direct branch from descending thoracic aorta, and the third branch is inferior suprarenal, which is a branch of renal. So there are three arteries which supply the suprarenal gland. I'll just tell you, listen here. The one, superior suprarenal, is a branch of inferior phrenic. Middle suprarenal is a branch of abdominal aorta, and inferior suprarenal is a branch of renal. So there are three arteries which supply the suprarenal gland. Tell me, how many veins drains the suprarenal gland? Veins. Three arteries. So how many veins drains the suprarenal gland? There's only one vein. Only one vein drains the suprarenal gland. Remember, on the right side, the suprarenal vein drains into what? IVC. On the left side, the suprarenal vein drains into left renal vein. Okay. On the right side, you can answer, who's this? This is the gonadal vein. On right side, drains into IVC. And on the left side, the gonadal vein drains into the left renal vein. This is different on both the sides. On the right side, the suprarenal and gonadal drains into IVC. On the left side, the suprarenal and gonadal drains into the left renal vein. Okay, what is the reason for this? It is embryological. Okay, this is gonadal vein and this is the suprarenal vein. Suprarenal vein. So that's suprarenal vein. Okay, so on the right side, suprarenal and gonadal drains into what? IVC. On the left side, the suprarenal and gonadal drains into the left renal vein. Clear why now? Why it is embryological in origin. So clear, blood supply of suprarenal gland is clear. One is superior suprarenal artery, two is middle suprarenal, and three is inferior suprarenal artery. Just wait one moment. Why is this difference on the right and on the left side? Okay, this is embryological, and just understand why it is like this. I'll put the slide later, just have a look. Why is this like this? Different on both the sides. Okay, I didn't tell you this before. So now you tell me. Once again, just have a look here quickly. Once again, quickly. What was this? This was the posterior cardinal vein. This is the supracardinal vein. This is the subcardinal vein. This is the hepatocardiac channel. This is the intersubcardinal anastomosis. And this is the suprasubcardinal anastomosis. Okay. He's not drawn this small vein here. There was a small vein here. What was that? The mesonephric vein. The right mesonephric vein. Okay. So the right mesonephric vein forms what? The right renal vein. The left renal vein is derived from one, the left mesonephric vein, the left subcardinal vein, and the intersubcardinal anastomosis. This was development of renal veins. How is the IVC formed? Look, the IVC is derived from one, the posterior cardinal vein, the supracardinal vein, the suprasubcardinal anastomosis, the subcardinal vein, and the hepatocardiac channel. This forms the IVC. Okay, this forms the IVC. And look, this is so nice. If this is going to be the IVC, tell me what will this be? What will this form? And what will this form? What will this form? What will this form? Tell me. This is going to form the suprarenal vein, and this is going to form the gonadal vein. And that is why the suprarenal and the gonadal on the right side, they drain into what? IVC. Whereas if you can tell me what is this entire vein on this side, this is the left renal vein. Remembering, this is the left renal vein. So now you tell me, who's this going to be? The suprarenal. And what is this going to be? The gonadal vein. And that's how on the left side, the suprarenal and the gonadal drain into the left renal vein, whereas on the right side, the suprarenal and gonadal drains into the IVC. Understanding? Clear to all of you? Yes? So that's it. So this should be clear. Suprarenal and gonadal drains into the IVC on the right side, and on the left side, the suprarenal and gonadal is going to drain into the left renal vein. That's the development of IVC. Okay, that's how it is. Then everything on the left side disappears off. This all things are gone off. This all things are gone. On the left side, no, all these things will degenerate off. All these things will degenerate off. Everything is gone on the left side. Everything is gone on the left side. Okay, clear to all of you? Look here once again. What is this vein going to form? That's the see, this is going to form our IVC, no? This forms our IVC. So what is this vein going to form? That's the left suprarenal vein. This will form the left suprarenal vein, and this is going to form the right suprarenal vein and the right gonadal vein. Sorry. So the right suprarenal and the right gonadal will drain into what? IVC. On this side, this entire vein is going to form the left renal vein. So this is the suprarenal and this is the gonadal. Okay, that's the concept here. Okay, so that completes it. I hope this is clear to all of you. Development of this was the last slide which I had drawn here. If you want, you can draw this slide. Superior suprarenal artery. Superior suprarenal artery. Superior suprarenal artery is a branch of inferior phrenic. Superior suprarenal artery is a branch of inferior phrenic. Middle suprarenal. Middle suprarenal is a branch of renal. And inferior suprarenal, middle suprarenal is a branch of aorta, and inferior suprarenal is a branch of renal artery. That's it. Clear to all of you? Arterial supply, it gets three arteries because it is very important for hormone production and all. So 3 arteries, but veins is different on both the sides. This is clear now. Okay, just one last thing I'll tell you. That's a different thing. I'll tell that later. That's a different thing. Okay, understand this now. I'll just tell you the abdominal part of the ureter. I'm not going into the pelvic part of the ureter because pelvis I'll have to explain you before I start with the pelvis and all. Okay, I'll just tell you the abdominal part of the ureter. Pelvic part will keep for later. Later we'll keep the pelvic part. Okay, I'll start. I'll just tell you a part of the ureter, then we'll stop. Wait, it's only 7:30. Starting with abdominal part of the ureter. Abdominal part of the ureter. Now pelvis I'm not explaining now. Once I finish with this with the lower limb now, then I'll start with the pelvis. Okay, I'll just tell you the abdominal part of the ureter because this relations you will not remember later. You have not written that, so that relations you have to remember. Okay, just 2 minutes, just 5-10 minutes more. We'll start. Now tell me, what is the length of the ureter? The length of the ureter is 25 centimeters. How many inches is that? 10 inches. And the ureters are completely what? Retroperitoneal. The ureters are completely retroperitoneal. I'll tell that later. Esophagus I'll tell you later. Just remember, hindgut I'll tell you. Hindgut is left, I know. That I'll tell you later in the pelvis and the perineum because that rectum and anal canal all will come there, no? Okay. Just 10 minutes more. Listen. The ureters, what is the length of ureter? 25 centimeters or 10 inches. Now, what is the length of ureter? 25 centimeters, and this ureter is completely retroperitoneal. What is the posterior relations of the ureter? Both the ureters are lying on the psoas major. Remembering, both the ureters are related to the transverse processes of the lumbar vertebrae or a muscle which begins from the transverse process. What's that? Psoas major, and a nerve lying on the psoas major. That will be the genitofemoral nerve. Genitofemoral nerve. So this becomes the posterior relations of the abdominal part of the ureter. Posterior relations of the abdominal part of the ureter. Okay, starting with ureter, just have a look at this. Rectum and anal canal, I'll tell you. I'll be telling you rectum and anal canal. That time I'll tell you the hind limb. Rectum and anal canal, I'll tell you. That time I'll tell you the hindgut. Okay. Starting with this, the ureters. A very important MCQ. Just have a look at this ureter. Lower limb I can't start now. Lower limb is a big topic, but lower limb is very easy. Okay, lower limb is very easy. Lower limb I'll tell you the next time. So lower limb is a separate topic altogether. Now that you know abdomen, lower limb will be very easy for you to understand because everything from the abdomen goes down into the lower limb. Okay, starting with ureters. Length 25 centimeters, that is 10 inches. Completely retroperitoneal. Completely retroperitoneal. Relations, posterior relations. 1. Transverse processes of the lumbar vertebrae. Transverse processes of the lumbar vertebrae, psoas major, and third is genitofemoral nerve. Transverse processes of the lumbar vertebrae, psoas major, and the genitofemoral nerve. Those who want to sit, you sit. Those who want to leave, you can leave. No problem. Okay, I'll just finish the ureter, the abdominal part, and then we'll continue. Then we'll stop. Okay, so the posterior relations of the ureter is the transverse processes of the lumbar vertebrae, the psoas major, and the genitofemoral nerve. Now, starting with the anterior relations of the ureter, just have a look at this. This is difficult ureter, anterior relations of the abdominal part of the ureter. Okay, I start here. Just have a look here. One moment. Here, see the slide. Now, this is a very important slide. Just one moment. We've seen this slide before, if you remember. See this slide. And just try to understand. Let us get clear. We'll start with abdominal part of the ureter, anterior relations. Okay, here we are, starting here with the anterior relations. Look at this, if you can answer this. We'll start. Tell me, this is the ureter. If you can see the slide here, that's the ureter. Just the abdominal part I'm telling you, and the rest is the pelvic part. Fine, the abdominal part of the ureter is related to, chalo, whatever you know, just think and answer fast. What is this part of the duodenum? Now you know everything because this we have done today itself, so you're fresh with it. So abdominal part of the ureter is related to, chalo, answer now fast, be fast. What is this now? This is the third part of duodenum. You remember the posterior relation of third part of the duodenum? That was psoas major and the right ureter. So now we're discussing the right ureter. The right ureter would be related to the third part of the duodenum. Now, what is this artery here? This is the superior mesenteric artery. This is the superior mesenteric artery. This is the superior mesenteric artery. And you remember the first branch of superior mesenteric artery which was going upwards, the first branch in the loop of the colon, inside the loop of the colon, the first branch. I'm not asking you the first branch, that was inferior pancreaticoduodenal. Inside the loop of the colon, which is this first branch, middle colic. What is this? Right colic. And what is this? What is this? Ileocolic. You remember this? And look, this is the ureter. You can see this. This is the ureter. So the anterior relations of the right ureter would be 1. What is this artery? The right colic. What is this artery? The ileocolic artery. Ileocolic artery. You understand? So anterior relations of the right ureter will be 1. The third part of the duodenum. Second, the right colic vessels. Third, the ileocolic vessels. And fourth, what is this? If you can tell me what is this? This is the root of mesentery. Root of mesentery. That's the root of mesentery. Okay, very good. You know now. You remember the structures crossed by the root of mesentery. One was the third part of the duodenum. Then was the aorta, the IVC, and the right psoas and the right ureter. You're following this? That is why I'm telling you this topic today only, because you're fresh with this. So the anterior relations of right ureter, once again, the third part of the duodenum, the right colic vessels, the ileocolic vessels, and the root of mesentery. Root of mesentery. What is the anterior relations of the left ureter? Look here, the anterior relations of the left ureter. That's the left ureter. You can see that. And now you can tell me what is this artery which is going up like this. Tell me which was the artery which was going up. That is why I've drawn the slide of the blood vessels of the arteries for you. This artery which is going up, this is the left colic. Left colic. Then what are these arteries? These are the sigmoid branches. Sigmoid branches. And you remember this inverted V-shaped mesentery? This inverted V-shaped mesentery was for what? Sigmoid colon, and this is known as the sigmoid mesocolon. So this becomes the anterior relations of the left ureter. Clear to all of you? So anterior relations of left ureter would be 1. The left colic vessels, the sigmoid vessels, and the root and the sigmoid mesocolon. Sigmoid mesocolon. Clear to all of you? So this is about the ureter. The right and the left ureter. So this is the abdominal part of the ureter. Pelvic part, I'll tell you when we're discussing the pelvis. Okay, we'll just finish this much part for the ureter. This will be easy to remember. Anterior relations. Very good, you know everything. Okay, anterior relations, right ureter and the left ureter. Very good, very good. You know this. So starting with right ureter. Right down. Third part of duodenum. So abdomen is very clear now. Third part of duodenum. Right colic vessels. Right colic vessels. Ileocolic vessels. Root of mesentery. Root of mesentery, and there's something else, gonadal vessels. I didn't show you that. I'll show you this later. Gonadal vessels. Gonadal vessels on either side cross the ureter. This was the first thing I told you when I was telling you the aorta. Gonadal vessels. And for the right ureter, there's one more, terminal part of ileum. Yes, terminal part of ileum. Okay, clear now why I wanted this to be known today only. This terminal part of the ileum is the last part of the ileum which is related to the right ureter. Left ureter is related to left colic vessels. Left colic vessels, sigmoid vessels, sigmoid mesocolon. I'll show you that. I'll show you that relations once again. Sigmoid mesocolon. Not middle colic. Middle colic goes up. Middle colic goes up, no. So middle colic is not related. Middle colic is not related. Middle colic goes up. Which middle colic goes upwards and then divides into two branches, which is the artery going like this, that is right colic, then ileocolic. Middle colic is not related. I'll show you the slide. I have not written middle colic, no. I have not written middle colic. I have written right colic only. Right colic vessels, ileocolic vessels. Middle colic artery goes upwards. I'll show you this once again. So that's about the ureters. The element of ureter, you know. Have a look at this slide once again. You done with this writing? Finish with this writing part. So what I'll be left with, you know, I'll be left with pelvis, perineum, the lower limb and the histology and some topics of general anatomy like joints and all. Okay, so these are all general anatomy relations. General anatomy. Posterior relations I wrote, no. Posterior relations, transverse processes of the lumbar vertebrae, psoas major and the genitofemoral nerve. Is this clear to all of you? Okay, have a look now. Look at this slide once again. Gonadal vessels on both the sides. Gonadal vessels are on both the sides. I have written only on the left side or what? Your gonadal vessels, sorry. Gonadal vessels are on both the sides, sorry. I'll show you the slide, just wait. Just one moment. Okay, where is that gone? Okay, look at this. I got the slide. Look at this slide. Fine, I got the slide. Here. That's it. Now just see this ureter once again. What are the posterior relations of the ureter? Yeah. Who's this crossing the ureter in front? Who's this crossing the ureter in front? Yeah. Sorry for this, one moment. That's a slide. One class will be done. One class, okay. So in that one class, I'll finish everything now, whatever is left. Have a look at this slide. Chalo, have a look at this slide now. Yo, that's a slide. Sorry for this. Yo, now I'll start. Now this is the ureter. Look at this. This is the ureter. And this ureter will be posteriorly related to what? What is this muscle behind? Psoas major. And what is the nerve lying on the psoas major? The genitofemoral nerve. And who's this crossing the ureter in front? This is very clear. Look, who's crossing the ureter in front? That's the gonadal vessels. That's the gonadal vessels crossing the ureter in front. Okay. Now see the posterior relations of the ureter once again. This posterior relation is clear. Now see the anterior relations of the ureter. God. Anterior relations of the ureter. Anterior relations. Now see this. I'm so sorry for this. The slide is going again and again. Okay, look at this now. Just 2 minutes. I can't magnify the slide at all, because if I magnify, the slide goes off, and if I don't magnify, you'll not be able to understand that. That is the reason. Just 2 minutes. Once again. It's again gone. And this is a very important slide. Here. General anatomy is a small topic. There's nothing much in general anatomy. Only the joints and type of joints have to tell you. Okay. Okay, look here once again, the anterior relations of the ureter, the right and the left ureter. Have a look. See here, anterior relations of the right ureter. Okay, I'll start. I'll see if I can magnify one last time. Okay, fine. Have a look at this. Okay, fine. That's it. I've got the slide. Have a look here. This should not go now. This will not go now. Okay, yep. Now understand this. What is this now? This is the third part of the duodenum. Okay. So anterior relations of the right ureter. One is the third part of the duodenum. Now what I'm telling you is the middle colic artery goes upwards like this. Now the middle colic artery goes upwards. What is this artery? This is the right colic artery. This is the ileocolic artery, and that's the root of mesentery. Okay. So what are the anterior relations of the right ureter? This is the third part of duodenum. That's the third part of the duodenum. That's the right colic vessels. Clear now? Right colic, because ileocolic goes up. Right colic vessels, ileocolic vessels, root of mesentery, and you can see this. What is this? The gonadal vessels. Okay. The left ureter is anteriorly related to the left colic vessels, the sigmoid vessels, and this inverted V-shaped mesentery is sigmoid mesocolon. Okay, and this is the gonadal vessels. If I don't magnify now, you'll not be able to see that. That is why I have to magnify the slide. Otherwise, there's no use of this slide. Clear now? See, this are magnified now. Now it will not go. Now, clear with the relations of the ureter. Once again, last time, the third part of the duodenum, the right colic vessels, the ileocolic vessels, the root of mesentery, and this is the gonadal vessels. The left ureter is related to the left colic vessels, the sigmoid vessels, the sigmoid mesocolon, and the gonadal vessels. That completes the ureter. Okay. Okay, sorry for that, but then no, if I don't magnify the slide, you will not be able to understand it. And if, okay, that's it. That's about the ureter. We finished with this ureters. Now after this is the pelvis, the perineum, and the lower limb. So next time when I start, I'll first start with the lower limb, and once I finish the lower limb, I'll start with the pelvis and the perineum, and then the histology. I'll be just showing you the slides, the important slides, and the general anatomy. General anatomy, just 1 or 2 topics are there. This is a very important diagram, and this diagram you have to know all these things. Okay, I'll just tell you one part. Terminal part of the ileum is not seen here. It's not seen here because ileum is intraperitoneal, no? So we have removed everything. These are the retroperitoneal structures that you're seeing. Retroperitoneal structures. Okay, I'll tell you rectus sheath. Fine. I'll tell you rectus sheath. One moment. Rectus sheath I'll tell you, then we'll stop. Rectus sheath I'll tell you. General anatomy is a small thing that I'll tell you next time. Understand this rectus sheath. Just 10 minutes, 5 minutes, I'll finish the rectus sheath. Look here. 5 minutes rectus sheath. So there is time, so I'll just tell you this. Starting with rectus sheath. Just 5 minutes, listen here. I'm not exhausted, how you people are exhausted. Okay. Now this is the rectus abdominis. It's very easy, it's very easy. This is the rectus abdominis. General anatomy, I'll tell you next time who's after general anatomy. Wait, no. That's the rectus abdominis. Okay. This is the umbilicus here. That's the pubic symphysis. Understand this rectus sheath. Just 5 minutes. Just listen here. Now, that's the xiphoid process. This is the body of the sternum. And these are the ribs. These are the costal cartilages and the ribs. Ribs. Now, we studied the rectus sheath in 3 parts. Just 5 minutes. Understand this. We studied the rectus sheath in 3 parts. One is about the costal margins. The first part is about the costal margin. The second part is below the costal margin and a line drawn between the umbilicus and the pubic symphysis. Second is below the costal margin and a line drawn between the umbilicus and the pubic symphysis. That's the second part. And the third part is below this line. Third part. Okay, so rectus sheath is studied in 3 parts. One is about the costal margin. Second, this is about the costal margin. About the costal margin. Second is below the costal margin and a line drawn between the umbilicus and the pubic symphysis. And this line would correspond to what, you know? Anterior superior iliac spine. Anterior superior iliac spine. So now understand this. I'll draw this as the rectus abdominis. Just 5 minutes. Wait 5 minutes. Don't sit and talk here. This is the rectus abdominis of both the sides. So this is one and this is one. There are two, no? One is this and one is this. There are 2 rectus abdominis. This is the second part, rectus abdominis. And that's the third part. Look, it's so easy and it's very easy to understand this. Now, in all the 3 parts, there's a muscle which comes in front here and interdigitates along the straight line. Who's that? Along this line, linea alba. What's this? External oblique. In all these 3 parts, the anterior wall is formed by whom? External oblique aponeurosis. That's external oblique. Okay. In the first part, the rectus abdominis, behind is no one. The rectus abdominis is posterior wall is deficit. These are the costal cartilages. Costal cartilages. Okay. Now, this is the first part. So, above the costal margin, the anterior wall of the rectus sheath is formed by whom? Is external oblique. Posteriorly, the rectus sheath is deficit. It is lying on what? Costal cartilages. Now, see the second part. In the second part, the anterior wall is formed by external oblique. The internal oblique comes here, and then it splits into 2 parts. One layer goes in front of the rectus abdominis. This is known as the anterior lamina of internal oblique, and one goes behind. Okay, so I'll make it like this. Look, I'll make it like this. This is the internal oblique which comes here and divides into 2. So this is the anterior lamina of internal oblique, and that's the posterior lamina of internal oblique. And the third muscle which goes behind is the transverse abdominis. The third muscle is the transverse abdominis. And this behind the transverse abdominis is known as the fascia transversalis. This is the fascia transversalis. Following this, so in the second part, that's between the costal margin, that's below the costal margin, and the line drawn between the umbilicus and the pubic symphysis, the anterior wall of the rectus sheath is formed by the external oblique, the anterior lamina of internal oblique. The posterior wall of the rectus sheath is formed by the posterior lamina of internal oblique, the transverse abdominis, and the fascia transversalis. Clear? And in the third part, below this line, all the 3 muscles go in front. All the 3 muscles will go anteriorly. The external oblique goes in front, the internal oblique goes in front, and the transverse abdominis also goes in front. All the 3 muscles goes in front. Okay, and who's lying behind here? Behind is only the fascia transversalis. Behind lies what? Fascia transversalis. Right? So all the three muscles go in front. This is external, internal and transverse. All the three muscles go in front, and who's lying behind? The fascia transversalis. That's how the rectus sheath is. It's very easy. It's very easy. Rectus sheath we study in three parts. One is above the costal margin. Second, below the costal margin and a line drawn between the umbilicus and the pubic symphysis. And the third part is below the line drawn between the umbilicus and the pubic symphysis. How do you remember this? In all the three parts, the anterior wall is formed by what? External oblique. In the first part, now, the anterior wall is formed by the external oblique, the posterior wall is deficit. The rectus abdominis is lying on the costal cartilages. In the second part, the anterior wall is formed by external oblique and the anterior lamina of internal oblique. The posterior wall is formed by the posterior lamina of internal oblique, the transverse abdominis and the fascia transversalis. Okay, and in the third part, below the line, all the three layers go in front: external, internal and transverse. And who's lying behind? The fascia transversalis. Okay, that's how you remember the rectus sheath. And this line, one moment, understand this. This line from backside, if you see, this is the first level, that's the second level, and that's the third level. And this rectus abdominis, if you see from behind, if you see this rectus abdominis from behind here, this we're looking from behind. This line behind is known as this one. This one is behind, is seen like this, and this is what we call as arcuate line. Arcuate line. This is the arcuate line. What does the arcuate line indicate? What does the arcuate line indicate? Above the costal margin. That's just above the costal margin. Okay, see this. It's something like this. Clear to all of you? It's very simple. I'll show you that. Just one moment. You've drawn this. Now see, if this is the rectus sheath, okay, if that's the rectus sheath from backside, you're looking from backside, you're looking this from backside. So which is this part, second part, and that's the third part. In the second part, the posterior wall is formed by what? Internal oblique, transverse abdominis and fascia transversalis. And in this part, below this, all the three muscles go in front. So who's behind here? Fascia transversalis. And this line is known as the arcuate line. So what does the arcuate line indicate? The lower border of the muscles. The lower border of the muscles is the arcuate line. I'll show you the slide, it will be clear. Third line, see, this is the line joining the two costal, the ribs. So this is level 1, this is second, and this is third. This is between the umbilicus and the pubic symphysis. I'll write that for you. Above the costal margin. Print out somehow. Above the costal margin. This is between the costal margin. This is between the costal margin and a line drawn between the costal margin and a line drawn between umbilicus and pubic symphysis. And this is the third part. Below this line. Okay, below this line means below this line. You're following this or no? Is this clear? It's very simple. See, one moment, I'll tell you, one moment. above the costal margin, and behind it is deficit. This and this, the first diagram I've drawn is like this, and this is a section. The second diagram I've drawn is a section. The first I've shown you the rectus abdominis like this, and then we have cut the rectus abdominis and we are seeing a section like this, section. The second part which I've drawn is a section. Clear now? It's very simple. This is the entire rectus abdominis I've drawn, and we have taken a section, and you're looking from the side here. See the slide, it will be clear to you. See the slide. Yo, I've got the slide, I've got the slide. Have a look at this slide. I've got the slide. Yo, that's a slide. Clear? Look here. That means it's very easy. I'll tell you that arcuate line once again. Look, this is the rectus abdominis. The first part is above the costal margin. The second part is below the costal margin, and a line drawn between the umbilicus and the pubic symphysis, and the third line is below that. Now you tell me, this is the first part, that's the second part, and that's the third part. That's a section. So what is this? External oblique. The anterior wall in the first part above the costal margin is formed by what? External oblique. Behind the rectus abdominis is lying on what? Costal cartilages. These are the costal cartilages. Okay. In the second part, the anterior wall is formed by the external oblique, the anterior lamina of internal oblique. The posterior wall is formed by the posterior lamina of internal oblique, the transverse abdominis, and this is the fascia transversalis. Fascia transversalis. And in the last part, all the three muscles go in front. This is external oblique, this is internal oblique, this is transverse abdominis. And who's this behind? Fascia transversalis. Fascia transversalis. Clear to all of you? Fascia transversalis. That's it. Clear to all of you? Now see this. There will be one anatomy class. I've told you, no, there will be one anatomy class. When that will be scheduled. That will be told to you later. Okay, just look at this thing. One last thing. Yo, see what I'm telling you is, look, one moment, just see that, no, rectus. Yo, look here. Now this is the rectus abdominis. Just understand this. Now this is the rectus abdominis. You're looking from backside. That's the second part, and that's the third part. In the second part, you're looking from backside. So this is the posterior wall of the rectus sheath. In the second part, the posterior wall of the rectus sheath is formed by what? The posterior lamina of internal oblique, the transverse abdominis, and the fascia transversalis. And in the third part here, what happens is all the muscles go in front. The muscles go in front. So who will remain here is the fascia transversalis. And this line, inverted U-shaped line, is known as arcuate line. So what does this arcuate line indicate? It indicates the lower border of the internal oblique and transverse abdominis. The lower border of internal oblique and transverse abdominis, because the rest of the muscles go in front, and this line is known as the arcuate line. I hope this is clear to all of you. Esophagus, I'll tell you later. Esophagus, I'll tell you. Okay. Okay, I'll stop here because now you people are not interested. You people are sitting and talking. I'll stop here. Esophagus, I'll tell you later. Okay.